also. So I think it's time we should start.
Okay, so just waiting, waiting for that IT guy. Uh, okay, so we are going on. Hello, everyone. Hope you are doing well and safe in whichever part of the world you are. I am Dr. Parin Patel, Head and Neck Surgical Oncologist at SCG Cancer Center, Ahmedabad, and also the organizing secretary for this conference. And I shall be your host today. On the behalf of this Oncosurgery Master Course 6.0, I welcome you all. In this era of webinars, left, right, center, we got the impression that the audience wanted more than the mundane transfer of this theoretical topic, hence keeping up with the traditional novelty of the oncosurgery master course. We, in our sixth edition, have decided to tread to a lesser known path of exploring the complications in head and neck oncology. And we have been blessed to have the over 1,000 registrations from not only uh, different part of India but also from the Pakistan, Nepal, Iran, Afghanistan, Sri Lanka, Indonesia, Bali, Nigeria, Kenya, England, Portugal, Australia, USA, Mauritius, Canada, Qatar, Zambia, South Africa, Jamaica, and many more. This has been made possible by the committed efforts of our team, and introducing to you the team OM 6.0. Oncosurgery Master Course was started before 6 years by the vision and the efforts of Dr. Kaustubh Patel and Dr. Rajendra Toprani, and they are the beacons whose light shines bright all over the event as the organizing chairman. The brains that have conceptualized the event, that is the course director, are Dr. Dushan Mandlik and Dr. Dakshesh Patel. The tireless work ethic and the micromanagement displayed by my fellow organizing secretary, Dr. Aditya Joshipura, and the core of the event, that is the scientific committee, Dr. Purvi Patel, Dr. Nitin Sharma, Dr. Dhanusha Goyal, Dr. Ashay Shah, Dr. Mitesh Patel. Obviously, the design and the coordination, for design and coordination, we thank to Mr. Sanjeev Dhawan, the main ideas behind this conference from Ahmedabad Cancer Foundation. Coming to the rules of engagement, in order to conduct a flawless session where the views of dignitaries are heard, the attendees will be muted. All the questions are to be posted in a group chat or on the question and answer box, out of which the relevant ones will be forwarded to the speaker and the moderator of the session. If the time permits, there will be two lectures by the senior faculties, which will be followed by expert panel discussion moderated by a master. There will be ample time given for entertaining the audience questions, so please be have patience. This is a series lasting for 6 Saturdays, taking up one subspecialty of head and neck, out of which today is the second episode. And what an episode it is! Today we will be dealing with the complications associated with the oral and oropharyngeal surgeries that require obviously the extreme skills and done very frequently in India, mandating the need to give a trouble-free course of the treatment to the patient. To open our innings, we have with us Professor K.K. Thankapan sir. Dr. Krishna Kumar currently serves as a professor at Amrita Advanced Center for Robotic Surgery and Center for Head and Neck Surgery in a department of surgical oncology, Kochi, Kerala. He has more than 40 publications in international journal, and also has written a book titled Basic Concepts in Head and Neck Surgery and Oncology. He will be enlightening us on the various complications in oral surgery, and we are delighted to kickstart our OM 6.0 in a grand style. And over to you, Dr. KK sir.
Thank you. Let me just good evening. I hope everybody can see my slides and hear me. Very okay?
Yes, sir.
Right. So good evening, everyone. The topic for today is complications in oral cancer surgery. I'm Dr. Krishna Kumar from Head and Neck Surgery and Oncology, Amrita Institute of Medical Sciences, Kochi. In today's talk, I'll be talking about the complications except in flap surgery, neck dissections, osteoradionecrosis, and systemic complications. I will not be touching on this because we have sessions coming up down the lane where we will discuss such topics. So at the onset, let me make some definitions. Complications are unexpected outcomes after oral surgery. Sequelae, it has to be differentiated from complications. They are expected adverse effects due to surgical manipulation of oral tissues. And morbidity is the adverse outcomes either due to complications or sequelae. Prevention of complications through careful techniques is always better than managing complications. Complications can be immediate, intermediate, or late. Here, watch out for some color in my presentations. In the future slides, you will see red color when I talk about complications and blue color when I talk about sequelae. So immediate complications can be, complications can be immediate, intermediate, and late. Immediate or intraoperative complications can be bleeding, nerve injuries, airway issues, or fractures. Intermediate or post-operative complications can be like hematoma, wound infection, secondary hemorrhage, wound dehiscence, necrosis and fistula, or airway obstruction. Here is a small video post-operative bleeding. This is a case of CA tongue, total gastrectomy, flap reconstruction, and second hemorrhage at the base tongue area. Okay. So we are trying to control it. Necros, the surrounding is all necrotic. We are not able to catch the bleeder. Okay, I'm trying to catch it with the help of an teeth process. No, no, I couldn't. I'm not able to control it. It's all necrosis issue. Still, I'm going again with the artery.
Yeah, 2 round body bike.
Again, I have no control. Now somehow I've got it, and now I'm asking for a 2-0 silk, 2-0 vicryl, and then I may oversewed the bleeder, and I could control it. Just to show a small case of secondary hemorrhage. Okay. Late complications or morbidity can be trismus. Trismus is a sequelae. It is not usually a complication. Malocclusion, masticatory issues, disfigurement, scar and aesthetic problems, nerve palsies, plate-related complications, swallowing and speech issues are usually and sometimes we cannot avoid it, and airway dysfunction. Here is as far as the intraoperative complication, I'll go into one specific case of infratemporal fossa bleeding. Okay, so here is the case. So here is a case of maxillectomy. I have done the cut, and the infrastructure is pushed down, and now we are trying to remove the posterior maxillary wall, and then the bleeding starts. And attempt is being done by using bipolar cautery in the infratemporal, in the pterygopalatine fossa. And then after that is controlled, I'm using bipolar forceps to take care of the pterygopalatine descending branch of the palatine artery, and then the pterygoid plates are cut, and then you get the actual intratemporal fossa brisk and profuse bleeding. Now, how do you control it? So when you come across this infratemporal fossa bleeding, there is usually a talk in the theater from the assistants and who are standing in nearby. They usually come and say, it's a pterygoid plexus bleeding, just pack it and it will stop. I always tell them it's not like that. The infratemporal fossa bleeding can be either from the artery or from the vein. And what are the vessels which are supplying the area? Branches of the maxillary artery or the pterygoid plexus. Which are the main artery? There is a maxillary artery with a mandibular part, pterygoid part, and the pterygopalatine part with a lot of branches. Like the mandibular part has a deep auricular, anterior tympanic, middle, and accessory meningeal arteries. They come through the foramen. Inferior alveolar artery. The pterygoid part has anterior and posterior deep temporal artery, mesenteric artery, pterygoid artery, buccal artery. And the pterygopalatine part has the posterior superior alveolar artery. And a vein is the pterygoid venous plexus. So the first thing is to identify whether it is an arterial bleed or a venous bleed. And if it is an arterial bleed, we have to catch that artery. And then only the bleeding will start. It will not just stop with the packing. So here comes the relevance of the compartmental resection. The limitation of the conventional approach is the posterior margin at the depth, the bleeding, and the fear of injuring the unknown. So the compartmental dissection, the principle is to remove the compartment as a whole in 3 dimensions, posterior to anterior. The mucosa comes last. The deep margin is dealt with first. The vessels are ligated first. The maxillary artery or the external carotid artery, as said, or usually the maxillary artery is identified and ligated first, and then the bleeding will be less. So that's the significance of compartmental resection to control the bleeding in infratemporal fossa tumors. So hemostasis in the infratemporal fossa, if it is arterial, can be dealt with a maxillary artery ligation. Any other small, if it is any other small vessels, the arterial clamping and ligation, bipolar cauterization, packing with Surgeries, especially if the bleeding is from the foramina. It is arterial, but then you can pack that foramina with the Surgeries, or you can use a bone wax. If it is a venous bleeding, you can go ahead with a gauze packing, a Surgeries or Abgel, and sometimes Surgiflow helps. So that's all about infra-bleeding. Complications of mandibular surgery. The mandibular surgery can be mandibulotomy, which provides access to the posterior oral cavity, the pharynx, and the infratemporal fossa. Marginal mandibulectomy for the tumors that abut the alveolus, and segmental mandibulectomy for gross bone involvement of the mandible. Do mandibulotomy only when it is absolutely indicated. We can take out almost all the tumors with the peroral approach, especially if it is combined with the transcervical approach. Especially, it's only required if there is a large parapharyngeal extension of the tumor. Then, and if it is a very vascular tumor, we may have to resort to a mandibulotomy approach. And the incidence of non-union and fibrous healing of plate in a mandibulotomy is around 7%, and the instability of the required osteotomy can be due to the geometry of the cut or inappropriate fixation. Infection sometimes happen. Fixation is usually done with the mini plates. The adequate number and appropriate plate and screws has to be used. What do you mean by adequate number? We usually use 2 plates, one at the lower border and one above it. The lower border plate has to be 2 bicortical, and appropriate length screws has to be used, and it has to be appropriately placed. Pre-plating has to be done. Not that we cut the mandible and then go for plating, but a pre-plating has to be done. And regarding the orientation and geometry of the osteotomy, paramedian mandibulotomy is always the best, and it is best to be done between the canine and lateral incisor, because the canine tooth has a diverging root. If you do it lateral to the canine, there is a chance that you hit the canine root, and that paramedian mandibulotomy preserves the nerves. The dose of the radiation is least in the anterior mandibular segment, and therefore paramedian mandibulotomy does not come in the field. You use a thin saw blade. We can use either a straight cut or a step cut. We usually prefer a straight cut. copious irrigation has to be done, and bone cuts has to be planned through the socket than between the sockets. Here's a small video of mandibulotomy. It's a very short video. We're using a thin saw blade, and that's a bone cut. So osteomyelitis, necrosis, and non-union can happen, usually after radiotherapy or chemoradiotherapy. Prevention is the best by proper fixation, good soft tissue coverage, watertight repair, and cover the hardware adequately. If at all it happens, this osteomyelitis, necrosis, or non-union, if at all it happens, treatment can be, we have to expose it, debride it, remove the old hardware, refix it, and some bone grafting has to be done, and a soft tissue cover has to be given. Hardware can be intraorally or extraorally. The wound will not heal. The hardware can be removed if the bone is healed. If it's not healed, again, we have to re-explore, remove the hardware, refix it with the splinting or intermaxillary fixation. Again, bone grafting and soft tissue cover has to be given. Malocclusion can sometimes happen. Prevention is important by appropriate fixation, pre-plating, and dental splints, which will help in the while approximating the bones to bring the teeth into occlusion. If at all it happens, if at a late stage, if you identify it, we have to explore it, re-osteotomy, bring into occlusion, rigid fixation with the reconstruction plates, and then bone grafting has to be done by using cancellous bone chips from the iliac crest. Teeth injury can happen, result of injury to the tooth root, and by not leaving enough bone around adjacent tooth. Again, bone cuts can be planned through the tooth sockets than between the teeth to avoid teeth injury and teeth loss. Nerve injury can happen while doing this thing. Usual nerve that can be injured are the lingual nerve, the mental nerve, and the marginal mandibular nerve. We have reported a paper. Rajiv Sharan is the first author, titled "Increased Plate and Osteosynthesis Related Complications Associated with Postoperative Concurrent Chemoradiotherapy in Oral Cancer." We have looked into around 60 patients in 3 groups: surgery only, surgery plus RT, and surgery plus chemo RT. And we found that the complications and the complication-free survival was the least in the group of surgery and chemo RT. So chemo RT is an important predictor of complications for plate and plate-related surgeries. Marginal mandibulectomy. The precautions we have to take to prevent complications. Actually, the decision has to be correct. When and in which patients whether we have to go ahead and decide to do a marginal mandibulectomy is important. Adequate exposure has to be given. A boat-shaped marginal mandibulectomy is preferred. This is all classical teachings. A 1 centimeter remnant bone should remain, and preserve the periosteum of the remnant bone. This is important because of the blood supply of the mandible. Mandible has an endosteal blood supply and a periosteal blood supply. The endosteal blood supply we may not be able to preserve while doing a marginal mandibulectomy most often, but periosteal blood supply is from the surrounding blood vessels like the lingual arteries and submental arteries and so on. So those has to be preserved. The periosteum has to be preserved so that the remnant bone retains the vascularity. Fracture can happen intraoperatively or later. So can be has to be used to cut the entire thickness and the length while doing marginal mandibulectomy. Avoid osteotomes. Most often, the last part we tend to use osteotome to make that remove the chip of the bone, and then the fracture happens. So that has to be avoided. Use the saw itself to cut the entire thickness and length. Avoid this procedure in post-RT patients. Avoid it in dentular patients where there is resorption of the alveolus, and the right angles of the cut has to be avoided. And sometimes, if at all fracture happens, we can do a plating and cover the plate with the soft tissue. Sometimes we do prophylactic plating if we feel that the remaining bone is less. Injury to the inferior alveolar nerve and vessel can happen. We try to avoid them, but most of the time it's very difficult to preserve it. The intention is to preserve the lip sensation and the endosteal blood supply. Here, one thing you have to keep in mind is that the canal is high, especially posteriorly, and the canal is closer to the mental foramen. It is inferior and anterior. So there is high chance that you injure this inferior alveolar nerve and vessel in marginal mandibulectomy while we are doing it posterior, and so we have to be careful in such positions. Malocclusion usually does not happen in the marginal mandibulectomy, but this is a case where we came across malocclusion. This is a marginal mandibulectomy and a radial forearm flap. And during the intraoperative manipulation, somehow the condyle slipped out of the fossa, and we were not able to identify it, and the patient presented with malocclusion. And this was corrected later. Segmental mandibulectomy, I think most of the complications and morbidity will be dealt with in a reconstruction session, but it can be reconstructed with bony reconstruction and soft tissue reconstruction. Here, note the blue color, the chin drift, the malocclusion, the swallowing issues, and deformity in soft tissue, only reconstruction of a segmental mandibulectomy is a sequelae rather than a complication. And guiding flange, sometimes a prosthetic appliance can be sometimes helpful in such patients. And here is another case of failed anterior mandibular reconstruction, which results in anti-gum deformity, which can cause serious functional issues like airway and swallowing issues. I'm not going to the details of the mandibulectomy and reconstruction today. Now coming to some other complications or sequelae. Now, trismus. The most important factor or predictive cause of trismus is the involvement or the manipulation of masticatory muscles. Here's a paper by Digistrastol. He's the man whom we always hear when we talk about trismus. And he has titled this systematic review as prognostic factors associated with a restricted mouth opening in patients with head and neck cancer. And he has found that this trismus occurs when there is a tumor near the masticatory muscles, and that requires extensive cancer treatment. That's very obvious. And restricted mouth opening usually occurs at six months after cancer treatment. Another paper which talks about the prevalence of the trismus in head and neck cancers, and they say the peak of trismus prevalence is at 6 months, and the long-term prevalence is about 30%. And high prevalence of trismus happens in oral and oropharyngeal substrates, and surgery plus radiotherapy resulted in high prevalence of trismus than treatment, and either treatment alone, that is surgery or radiotherapy alone. How can we treat trismus? Like physiotherapy or stretching exercises, or surgery like surgical scar release, coronoidectomy, and flap interposition. Flaps can be either radial forearm, nasolabial flaps, or palatal flaps. And this is a picture of some devices which can be used for stretching in prevention and treatment of trismus. We have reported one case where we used a cross stick dumbbell-shaped radial forearm flap for a simultaneous correction of oral cancer and submucous fibrosis. Here's a case with one-sided submucous fibrosis and other-sided oral cancer, and then we resected the tumor, we released the fibrosis on the opposite side, and then placed the radial forearm across the soft palate like this, and this is the outcome of the case. Nerve palsy can be related to facial nerve, hypoglossal nerve, lingual nerve, inferior alveolar, or mental nerve. Marginal mandibular nerve injury can usually happen after neck dissection, but it can also happen while doing a lower cheek flap. If you identify it immediately, repair it by direct suturing and grafting. If it is an established paralysis, it's a very difficult problem. It can be dealt with occasionally with a platysma transfer, digastric transfer, and sternohyo transfer. We have tried all this, but the results are usually not great. Lingual nerve injury, we talked about it. We have to be careful while doing a mandibulectomy and posterior marginal mandibulectomy. The anatomy of the lingual nerve has to be kept in mind. It comes very closely in the retromolar trigone area. So when we do the cut there, either segmental mandibulectomy or a marginal mandibulectomy, be careful to preserve the nerve, if at all preservable. In many cases, it's not preservable because of the tumor, but if at all it is preservable, be careful that such a nerve exists there and look for it and try to avoid it. Here's another small video of a lingual nerve tracing. It is a segmental mandibulectomy. Uh, we are You can see the specimen laterally. This is the mylohyoid muscle and the inferior alveolar nerve. We are trying to preserve it, but we realize that it is close to the tumor here, and therefore we decide to sacrifice it. But keep in mind that such a nerve exists there and try to preserve it if at all possible. Orocutaneous fistula. The causative factors can be amount of the tissue resected, completeness of resection, completeness and appropriateness of reconstruction, success of reconstruction, and patient factors like comorbidities, previous treatment, nutrition status, thyroid status, steroid use, and oral hygiene. Here is a case treated outside a carcinoma alveolus, which was excised, and a free iliac bone graft was used with wiring, and post-operative radiotherapy was given and resulted in this orocutaneous fistula, obvious. So so it had all the problems. The free non-vascular bone was used, wiring was done, and no soft tissue proper cover was given. And we had to remove all the skin, all the bone, and finally fibula was used with the skin paddle, and this was the final outcome. Fluid collection, if at all it happens postoperatively, it can present with pain, edema, and erythema. Imaging may be done with an ultrasound or a CT scan. Aspiration can be done. The stitches can be released and allow the egress of pus and saliva. Wound should be opened as anteriorly as possible. Keep the patient nil by mouth. Wound irrigation care, packing, and appropriate antibiotics. Healing may take many weeks. Non-healing fistula may be due to the presence of the tumor, malnutrition, distal obstruction in the pharynx, a foreign body like a suture material or a hardware, systemic problems like diabetes or hypothyroidism. There's a paper from Tata, a review of 587 patients, factors predisposing to development of orocutaneous fistula following oral cancer surgery. They looked into 587 patients and they report 9% development of orocutaneous fistula. And on univariate and multivariate analysis, patients undergoing bilateral leg dissection or with surgical site infection were at the maximum risk for orocutaneous fistula, and majority, that is 57%, required surgical intervention for management. There's another paper from Tata again. They say the 30-day morbidity, the most common 30-day morbidity is the orocutaneous fistula, about 9%. And what they are telling is it is related to the presence of orocutaneous fistula is related to the overall survival. Very important point. When a patient develops an orocutaneous fistula, the survival will ultimately be less, it seems. Airway complications can be due to dislodgement of the endotracheal tube, foreign body, hemorrhage, hematoma, swelling, edema, mucosal obstruction, and aspiration. Keep in mind, re-intubation may be difficult in a post-surgical or a post-radiotherapy patient. The prevention is by appropriate and timely tracheostomy. Our indications for tracheostomy are all free flap reconstructions, intermaxillary fixations after oral surgery, elderly patients, comorbidities, short neck, obese, restricted neck mobility. Here, all such cases, keep your threshold for doing a tracheostomy low, because at the night there may not be an experienced anesthetist available to re-intubate and secure the airway. So if you have a tracheostomy, at least in the initial periods, it will save the life of the patient. Interestingly, another paper which talks about the morbidity and mortality related to tracheostomy itself. They studied 51 patients and they say the morbidity due to tracheostomy can be up to 35% in 18 of out of 51 patients. Can be like a tracheitis, obstructive tracheostomy, displaced tracheostomy, air leakage, stomal dehiscence, and decannulation failure. So tracheostomy itself is not a simple thing. We should have experienced people to manage tracheostomy too. Post-operative diet and prevention of aspiration is important. A swallowing evaluation has to be done. A Ryle's tube or a peg feeding has to be appropriately initiated. Monitored restart of oral feeds to prevent aspiration. Prolonged dysphagia may require a swallowing therapy and supportive care. Surgical site infections is also worth mentioning. It can happen in 10 to 45% of cases. Infection within first 30 postoperative days with at least one of these several factors, including purulent discharge, positive culture, either a deliberate incision and drainage, or the presence of suppurative signs and symptoms, should be there to call it a surgical site infection. It's usually polymicrobial with aerobes, anaerobes, gram-positive and negative bacteria. Prophylactic antibiotics has to be appropriately given. The appropriate regimen and duration has to be chosen. Most of the papers, if you go, they say the prophylactic antibiotics is usually enough for only 24 hours. But we feel that dictum is not relevant in Indian situation because of our poor oral hygiene or something. We looked into that. We sort of resorted to only 24 hours prophylactic antibiotics for about 2 months. And finally, we came up and we saw that the surgical site infection rates were up to 50% when we are limiting up to 24 hours. So now we give anti-sulbactam for at least 5 days, 5 to 7 days, at least 5 days post-operatively. And then we have got a better prevention of surgical site infection. I'm concluding my talk with the last two papers. One is from Divya et al. From RCC Trivandrum, where she has looked into the risk factors for post-operative complications in primary oral cancer surgery, a prospective study of 676 patients, and on multivariate analysis, presence of COPD, full thickness wide excision, and increased duration of surgery seems the major independent risk factors for postoperative complications in oral surgery. Another similar study looked into the risk factors for postoperative complications of 110 patients, where they found a bilateral neck dissection and the Apache score, that's a functional score of 2, as the most important predictive factors for post-operative complication. What is more important is in this paper is the point which I came across in one of the data papers, that this complications has an impact on the survival. This is a Kaplan-Meier survival care curve with this curve is with no complications, and the middle curve is with the only local complications. And when there is local and systemic complications, your survival is the least. To conclude and summarize, morbidity after surgery can be either complications or sequelae. Complications after oral cancer surgery can be immediate, intermediate, and late. Appropriate steps can prevent these complications, and managing complications is more difficult than preventing them. Thank you.
Thank you, KK sir.
Thank you.
There are the two questions that I would like to present from the audience. One is from Dr. Mayuri. She wants to ask how to prevent a skull base fracture during compartmental ITF clearance.
Skull base fracture, it's a very good question. We used to discuss this in the OT. So after exposing, one of the step is the disjunction of the pterygoid plates from the skull base. Here I saw in the video we have to use either a sharp saw or a drill rather than an osteotomy. Sometimes if you tend to make a small partial cut and tend to go with an osteotomy to disjunct the pterygoid plates from the skull base, fracture can happen. The fracture line can extend in the skull base, and to identify skull base, appropriate exposure has to be done, and then use a saw or a drill to cut it, and this will prevent a skull base fracture.
Okay. One more question from the panel, this attendees. Whether you will perform the tracheostomy in all free flap?
Yes, we usually perform in all free flaps, except very young patients where we do ameloblastoma surgeries, where they are where it's concerned about the the scar in front of the neck. Very young patients with ameloblastomas. The reason is that not because the airway is fully obstructed during the surgery. It will be obstructed, but these patients, our threshold for the re-explorations are very less. So the re-exploration decision will be taken in the middle of the night. This patient has to go back to the theater to look at the flap. At that time, an experienced anesthetist may not be available for re-intubating your patient, and tracheostomy will save the problem. So that is one reason rather than the obstruction, of course. And also in elderly and such patients, because of the comorbidities, in elderly patients, they will have problems in expectoration. They will not be able to bring the secretions out. So if you are not doing a tracheostomy, these secretions, they will be swallowing or they will be drowning in their own secretions, and pneumonia and such complications can happen. So especially elderly comorbid patients, you have to do a tracheostomy, and in pre-flaps, this is the indications.
Thank you, Dr. KK. After that inspiring and the in-depth talk by Dr. KK, we move on to the man who doesn't deserve any
Thank you all.
require any introduction. It is a Dr. Shamit Chopra. He is an attending and chair Department of Head and Neck Surgery, Patel Hospital, Jalandhar, India. Current program director for fellowship program uh, in head and neck surgery, affiliated to AOMSI and FHNO. He has over 45 published abstract and 12 complete manuscript in index by US National Library of Medicine. He will be talking today on the various complications in oropharyngeal surgery. Welcome, Dr. Shamit Chopra.
Hi, Paran, am I audible?
Yes, sir.
Okay. Can you enable my screen sharing option? It's not allowing me to do that.
To make him host. It is there, sir.
Is it disabled it? So
1 minute, sir.
I'll take this opportunity while Paran is setting it up to thank everyone and yes, in front of professors and everyone and our esteemed colleagues, I really give a lot of credit to the HCG Ahmedabad team for taking the initiative yet again. Excuse me.
It's on, sir. You are.
Yeah, sure. So taking the initiative yet again in ensuring that we really move strength to strength in terms of knowledge sharing. It might have been a difficult time for the world, but it's been a great time in terms of knowledge sharing, and hopefully we can help take it further. So congratulations, all of you, and I hope I can do my bit in this as well. So after KK's detailed talk, can you hear me and can you see the screen?
Yes, sir.
Great. So after KK's detailed talk, and he spoke about oral cancer surgery, there's a fundamental difference in oropharynx and oral cavity, as all of us know, because the focus is on organ preservation, usually non-surgical in oropharynx. So the kind of issues that we encounter are in some ways similar and in some ways disparate to what we encounter in oral cavity cancers. But without further ado, we'll move forward. So at the outset, because the theme of this meeting is complications, we need to get the ball rolling and let you guys know that it is different. There are medically accepted definitions for complications, adverse events, and sequels. A sequel is an anticipated recurrence. So a short-term tracheotomy dependence after an oropharyngeal cancer resection cannot be called a complication. But yes, long-term tracheotomy dependence, long-term dysphagia may be labeled a complication. It's all pretty variable and subjective in terms of counseling our patients, and a lot of our patients will remain potentially NG and enteral support dependent. Having said that, it's important to get that approach straight first of all. There are specific complications of surgery incorporating the oropharynx, and going from general to specific, we need to realize that immediate complications are by and large similar to what Dr. Krishna Kumar talked about. It's early and late, where the divergence actually begins. And of course, we can try to explain each of them by pathophysiology. And remember, our complications on oropharynx talk will end up lasting the whole day if we were to talk about all of them. But we'll have 4 issues for you. And those 4 issues will probably highlight what we are going to talk about here. So in terms of pathophysiology, look from left to right. The resultant complication of delayed wound healing at tumor site could potentially result in the following complications: the pharyngocutaneous fistula, vascular complications in terms of blowouts, and once a fistula heals, it heals circumferentially, so you get stenosis. From delayed approach, resection, reconstruction are all 3 hallmarks of oropharyngeal cancer surgery. And if you have done a mandibulotomy, for instance, you can have hardware exposure mandating removal. You can get malocclusion, non-union, sway, and just like a circumferential healing of a fistula results in stenosis, healing of a sway can potentially result in secondary trismus. So it's extremely important that we realize that delayed wound healing at tumor as well as access site, that's where the divergence begins a little bit from the oral cavity. If the pathophysiology indicates that your patient is moving with issues with flap bulk and native tissue redundancy, you can have tracheotomy dependence. And that's, of course, not a good thing, especially if you've counseled the patient that the rate of tracheotomy long-term dependence is low. And of course, our airway swallowing the incredibly complex structure like the larynx, there's always alteration of dynamics when we operate on these patients. So all of that results in what we'll be focusing on for at least half of this presentation: aspiration, dysphagia, and requirement of long-standing enteral support. To me, the 4 issues that we'll highlight, we'll talk about these resultant complications and hopefully have some answer at the end of this presentation and the discussion that I'm sure is going to ensue. When we talk about surgeries which incorporate oropharynx, remember the oropharynx is a dynamic structure. Therein, a resection of a structure that's going to incorporate the oropharynx will also probably have oral cavity component and might also have a laryngeal-hypopharyngeal component. So what are our challenges? And I tried to really kind of break it down. As you're seeing a picture with an intact larynx and an oropharynx inset with a monitor paddle, let's try to talk about that. You need access for complete oncological control as well as insetting. There's no point if you've managed to get away with an approach that does not require a mandibulotomy, and therein you end up with an issue which does not allow you to inset your flap proper. So remember, you need good access for oncological control as well as insetting. We talked about volume restoration very briefly, and we'll talk about it a little more. You want to really do what is ideal. You don't want extra bulk, but you also don't want a full thickness skin graft over there, right? So you want to restore the volume and you want to obviate long-term trach and enteral dependence. Even though it might sound much easier said than done, but yes, you at some point of time, you do want that the flaps which are adynamic are able to use the residual dynamic tissues as strut, which is something we use for the oral cavity, like a hemiglossectomy all the time. And you want to propel the food bolus and really initiate that second phase of swallowing. Easier said than done, like I said, but hopefully, and that is our aim in making sure that you offer an optimized outcome to these patients. There are, of course, functional issues with an intact as well as resected larynx, and there's a little bit of a reality check because by and large, you're dealing with issues that are specific to a hypoxic environment. We talked about radiation therapy already having been done in if not the vast majority, then a reasonable majority of these patients. And another reality check, in our experience or based on my understanding, over pre-treatment an improved functional state is generally not achievable, which means that if a patient has a tumor that's causing impediment in swallowing and airway, for the most part, you're not able to improve function. However, the experienced head and neck surgeons in the audience would say, no, that's not really correct. So that's why I put this caveat over here. The exception, in my opinion, is a dysfunctional larynx, which necessitates a resection at the same time, which means you can't aspirate and you're not tracheotomy dependent if a laryngectomy is performed concomitantly. So yes, those patients have an improved functional state over pre-treatment, but for the most part, the oropharynx is a very challenging ground as far as optimizing function is concerned. But broadly speaking, these are the goals that we talk about when we talk about oropharyngeal surgeries, be it primary or salvage. So what will we talk about today? We'll talk about from bottom to top. We'll talk about reconstruction. We'll talk about the appropriate reconstruction to prevent the 2 complications that bother us the most about oropharyngeal surgery, a pharyngocutaneous fistula and dysphagia following oropharyngeal resections. We will talk after this very briefly about mandibulotomy, a few technical perspectives and avoiding complications and the modifications thereof. And again, this is common ground with what Krishna Kumar has talked about and what Arun will probably be talking about as well. So we'll lean over it very quickly. And of course, no current talk on oropharyngeal surgery is probably complete without TORS. So we will talk at the end very briefly, if Parin allows us time, to talk about not just complications obviated, but potentially created by TORS. And again, another reality check as we go on. Let's talk about issue 1. And we're going to start off with reconstruction right away because according to me, the issue of pharyngocutaneous fistula and reconstruction goes hand in hand. Interesting study following oropharyngeal PCF. There were factors that achieved significance in terms of causation of pharyngocutaneous fistula, which either achieved or tended to significance. The ones at the top are the unpreventable factors in terms of whether or not free flap tube or patch was utilized, or whether all flaps tube or patch was utilized. As you would imagine, tube reconstruction of the oropharynx was typically associated with a higher rate of pharyngocutaneous fistula. and the T stage. Of course, a bigger resection will require more tissue to heal, will involve more violation of vascular watersheds, and therein result in more issues. The ones at the bottom were correctable factors. The size of the flap, which is something we started talking about, and we'll go a little bit further into this. Pre-op hemoglobin, albumin, so anemia and hypoalbuminemia are correctable, and you sometimes want to admit and optimize these patients before you go ahead. Diabetes, again, as all of us know, and this is the table on the right, which kind of highlights what we just talked about. Do remember the things listed on the left are remediable factors for pharyngocutaneous fistula based on our MDT's opinion and what we try to typically correct. Infection prior to surgery, low albumin, low anemia, dysthyroidism, diabetes. Thrombophilia screening forms an essential component of salvage reconstructions when you have to use especially free flaps. So thrombophilia screening has now become an essential part of workup for microvascular reconstruction. This paper is something we've started using a fair bit. One of my mentors, Dr. Gregory Farwell, is at UC Davis, and he was one of the lead authors of this study, which talks about enhanced recovery after surgery. And these are the guidelines we are trying to follow as we go on.
I think Dr. Pari.
I think Shamit is cut off probably.
Yeah, I think Shamit is cut off.
Yeah, I think
maybe he has suddenly he might have internet issue and he might have exited. So we will contact him. But meanwhile,
I will take some questions from the attendees, sir.
Yeah.
KK sir, there is one question from Dr. Vikram sir. Okay, what is the best management of salivary leak?
Right. Salivary leak has to be, first of all, is it back?
Samit sir is back.
Yeah, sorry about that, Parin. Can you hear me?
Yeah, sir.
Yeah, great. So enable screen sharing, but I'll wait for Dr. KK to finish his comment. I apologize, I was cut off for 2 minutes.
Continue.
Continue, sir.
Okay. Okay, great. You have the visual, right?
Yes, sir.
Okay, great. So remember that when we talk about flap selection, and that was the last point that we listed on the last slide, the flap selection is largely dependent on a combination of patient factors and tumor factors. So you're looking at age, comorbidities, and we look at NSQIP, and I know the Amrita group has done a lot of work on that, and we are about to present our data fairly soon as well. Surgical candidacy, local trauma, and preference would typically form part of the patient factors, but there are also tumor factors. And there is sometimes that we try to bridge the divide by really looking at what resected tissue is going to be and what the stage is going to be. And the bulk we talked about already, but one thing that's often overlooked, especially in oropharyngeal cancer surgery, is the one that I've pointed at the bottom, which is the flap pedicle geometry. I think each one of us as microvascular surgeons and even as pedicle reconstructive surgeons is very mindful of the fact as we grow longer in our practice and we see our rates go much better simply because we paid an extra few minutes to flap pedicle geometry. Of course, we can't have a conversation about oropharyngeal reconstruction without talking about radiation therapy. So when we talk about radiation and flap selection in oropharyngeal cancer to prevent a pharyngocutaneous fistula, you can divide it into two. If radiation therapy was anticipated and if radiation therapy has been given prior. If radiation therapy is anticipated post-oropharyngeal cancer resection, then you have to overcorrect your defects to a factor of between 30 and 50%, depending upon your individual philosophy. However, if you have prior radiation therapy, then the picture on the right is something that applies. It's really a hypovascular environment. Remember, it's a triad of hypocellularity, hypoxia, and hypovascularity. So you will have issues with radiation vasculitis, more prominently arteritis, which we face very often. So you want to go a little bit farther from the epicenter of the radiation field. And a vessel depleted neck is sometimes, which really vexes us in terms of not being able to find the right reconstruction for these patients. And in these patients, optimization of outcomes is frankly not possible to the extent that we would hope for. So, pharyngocutaneous fistula, we talked about the factors that are potentially remediable, and we also talked about radiation therapy, which is going to increase the fistula rate. But at the end of the day, you really want to make sure that you select your flap correctly, and thereby you are able to prevent that. I think the main focus of what I discussed with Dr. Kostub and with Parin was that we are going to follow an algorithm of prevention and then detection. So essentially in PCF, we've talked about prevention of a complication. What about management of swallowing issues, which are pretty much a standard correlate of all oropharyngeal cancer resections? Remember that a disease like the one that you're seeing on the radiological single coronal image, but you can see the tumor extending up to the pharyngeal tongue in the midline. And there is a functional correlate of swallowing and aspiration. So whenever we talk about swallowing, we also talk in extrapolation about aspiration. As you can see, by virtue of these studies that you're seeing from the late 90s and the early 2000s, that as you start resecting more base of tongue, the aspiration starts happening and the swallowing efficiency is reduced. But at the bottom, it's reduced to the extent of really there being no bolus propulsion. As you can see in the animation on the top, you will be able to get bolus propulsion in a significant majority of your patients if you have an intact base of tongue. If you don't, then the problem is actually much more severe with oropharyngeal resections compared to oral cancer resections. How do we solve it? Of course, it's important to talk about a complication, but it's even more important to talk about solving it. Remember that there are multiple ways that we can look at it. When we talk about pharyngeal tongue reconstruction, it's essentially a choice between the devil and the deep sea. We already alluded to undercorrection and overcorrection. If you overcorrect, you get the problems on the left. And if you undercorrect, then you get the problems in the middle. How do you achieve a balance? We try to look at functional outcomes of tongue reconstruction presented in AHNS 2018. And these were essentially subjective outcomes. As we go more objective, and we've done that for oral cavity, we're yet to do it in oropharynx. But we are realizing a trend of patients reconstructed with free flaps doing potentially better in terms of dysphagia. Having said that, there's always a selection bias. A severely comorbid patient might or might not be a candidate for a free flap. Therein, you expect the pharyngeal constrictors to also be more innervated and so on and so forth. But again, it needs to be taken with a pinch of salt, and it has the limitations that any reconstructive literature would have, which is low level evidence. But having said that, it's something worth thinking about when you talk about pharyngeal reconstruction of the pharyngeal tongue and the dysphagia that's resultant from it. We talked about prevention of PCF in issue 1, and we'll talk about early detection. Like the 5-point brief for me in terms of this conference is you should be able to detect dysphagia. How do we detect it? A patient comes to you, looks fairly fine, but there are some trigger points. And I'll go over it very fast because this is all stuff that you can easily get from your references. But there's multiple trigger points for dysphagia evaluation, and these are all. And it's useful to have a questionnaire, which we have in our clinic. And of course, the ones who have much bigger dedicated dysphagia clinics have also been doing it for a while. But the trigger point triggers essentially a screening test as well. A lot of us, especially the more experienced proponents of head and neck cancer, will be doing a trial water swallow test. And for the patients who've already been decannulated, for the patients whose NG has already been removed, this constitutes a very good screening test for early or late dysphagia. Remember, early dysphagia within the matter of a few months after the patient has had his or her adjuvant therapy would typically be something which would lend itself much easily or amenable to evaluation. But if a patient is diabetic, be aware, you might need to do an objective test because a lot of these patients will be silent aspirators. Also, there is evidence that patients with oropharyngeal primaries are microaspirators at diagnosis in 20%. And if you give them non-surgical organ preservation therapy as a definitive option, you will make them about 50 to 60% of them aspirators. So it's extremely important to do a pre-treatment fees. And we've incorporated that as part of our protocol in all oropharyngeal cancer patients before recommending definitive treatment. If a patient is frankly aspirating, understandably, that patient will not get non-surgical organ preservation or even surgical organ preservation for that matter. There are some questionnaires that you utilize in addition to the trial water test. These are the two that we use. The EAT-10, which again was Dr. Peter Belafsky, one of the attendings I've worked with at California. And of course, the MD Anderson dysphagia inventory. And we'll talk a little bit more about that. The EAT-10 is a general tool that we use for dysphagia evaluation of oropharyngeal cancers in the initial setting. It's easy to administer. It takes 2 minutes to fill out. It's self-explanatory. Patients typically don't need a physician's help to fill it out. anything more than 3 out of a score of 40 typically indicates further evaluation. And even though data does not compare a global scale or a psychosocial scale like the MD Anderson dysphagia inventory is, it does not really, a trigger point of evaluation should not eventually lead to a global scale, but we still, for lack of a dedicated head and neck specific screening tool, we still end up using the MD Anderson dysphagia inventory because in our opinion, it is a comprehensive inventory after all. For the patients who are positive, we end up recommending more objective testing, and they essentially include video fluoroscopy. As you can see in this patient, these are the steps of a normal swallow, and you are seeing no pharyngeal residue or none of the parameters that we're noting. And this is one of our patients who had an oropharyngeal resection with an intact larynx. And you can see this patient at the bottom that, yes, he's able to propel the bolus. It was a small oropharyngeal resection, open oropharyngeal, not or. So you can see the clips just above the epiglottis or just adjacent to it. There is some pharyngeal residue. So that is, of course, an ideal outcome, but we'll show you non-ideal outcomes also as we go on. The FEAS is another good tool, and that usually is beneficial because you can do it at the same time as a fiber optic laryngoscopy for primary disease diagnostic or for surveillance purposes. A FEAS really adds a fair bit to what we try to achieve with the video fluoroscopy. Another postoperative patient here, and you are seeing, and again, intact larynx, you can see the knobby epiglottis. That's indicator of the fact that the patient also received adjuvant therapy. So slightly different from that, but again, an outcome which you would be okay with in the first stage of VFS in terms of being able to rehabilitate these patients. Of course, both of these investigations have their limitations. We talked about detection now. Treatment of dysphagia in oropharyngeal cancer patients is essentially rehabilitative and compensatory, and it's important for us to realize that. There are certain compensatory strategies and certain rehabilitative strategies that are able to help us when an oropharyngeal cancer patient presents with dysphagia or has a simple question like he's not able to swallow solids. The normal reaction of us as surgical oncologists, site-specific or otherwise, will be to attribute it to radiation therapy. And that's very important because xerostomia is also a correlate of dysphagia. Having said that, it's much more important to rehabilitate them from a xerostomia standpoint and really talk a little bit more about trigger points, talk a little bit more about evaluating this patient a little further. The patient might have swallowing phobia simply because he's aspirating and would not share that thing. So a trial water test is beneficial. A trigger point evaluation is helpful, and therein you go ahead with dysphagia. Postural measures are important in being able to decide what patients, which patients of ours are going to need basic therapy. For instance, they are the easiest way to do it. So in this patient, you are seeing that there is significant pharyngeal residue in the vallecula after swallowing. But this, again, the same patient, after swallowing therapy and a few days, you can probably see that this patient is now with a compensatory measure, like you'll see a head tilt at the end, and he's able to get all of his bolus down. So there's multiple things that would help us, and there are other postural changes also, not in the ones that we talked about earlier, but there are other postural changes which are able to help rehabilitate these patients with regard to dysphagia. There are techniques to improve oral sensory awareness and change the volume and speed of food presentation. And there are prosthetics and dietary changes. And again, if any of the trainees would be interested in this presentation, I'll be able to send this to them so that they have a ready reckoner in their clinic in terms of rehabilitating dysphagia and oropharyngeal cancer. There are resistance exercises, and in the interest of time, I will not go too much into it, but there are maneuvers as well. And this is something that most of us are familiar with, the supraglottic swallow, especially for patients who have had some degree of oropharyngeal and supraglottic resection. So we started talking about reconstruction in terms of selecting the right flap for prevention of PCF. And remember, it's easier said than done. But talking about reconstruction for recurrent disease in the oropharynx is something which is, again, not supported by evidence. So it's essentially your or my best possible interpretation of the available evidence, as well as whatever is available in our armamentarium. These are a few principles that are noted down because most of these patients that you treat with oropharyngeal cancer, post non-surgical organ preservation are going to be residual or recurrent. We believe that the principles of reconstruction for newly diagnosed oropharyngeal disease are extrapolatable to recurrent disease. We also believe that flap selection is dictated by recipient bed. So you really want to do a complete evaluation of your donor and recipient vessels before you start selecting whether or not that patient is a candidate for microvascular reconstruction. If you work in a center that has the expertise in interposition vein grafts and really tries to use distant sites, by all means, go ahead with it. But a reality check before you go in with this, there is a learning curve involved here. We think that distant vascularized tissue is potentially more suitable for a hypoxic environment. So don't try rotating flaps, local and regional flaps, unless they're distant axial in reconstruction for recurrent oropharyngeal disease. We talked a little bit about comorbidity scoring. It assumes even greater importance when we're talking about reconstruction for recurrent disease to really have a holistic approach of what the expectations of the patient are. Like we mentioned, the reconstructive aims are much more somber than they would be in primarily diagnosed disease. A couple of technical pearls: always find donor vessels prior to free flap harvest. And as you can see over here, there's just going to be an artery or two that sometimes you'll be able to find in woody heart induration. Try to consider donor vessels with a higher pressure head. And even though there are devices to measure it, you can just make it subjective after dilating the vessels. And of course, these 2 points apply only to microvascular reconstruction. Remember that pedicle flaps are a viable option in this subset of patients. Prior incisions and vascular watersheds must be respected regardless of whatever reconstructive option you choose. If you're doing a neck dissection, you might not need a redo because of the high negative predictive value of a PET CT, which is an essential component of following your patient. So don't really go in and start exposing those vessels unless you really need to. And of course, I heard Dr. Krishna Kumar talking about all free flaps typically requiring a tracheotomy. Our philosophy and message in recurrent oropharynx is very simple. Recurrent oropharynx typically will get a tracheotomy virtually every single time because the extent of edema that you get of the larynx, even though there's no disease close to it, will potentially mandate a tracheotomy. You don't really want to be in a borderline airway situation, and you really want to give airway support to these patients. So winding up the issue of reconstruction and trying to avoid the 2 complications that we talked about, dysphagia and PCF. We moved past PCF and moved to some extent past dysphagia, but for advanced oropharynx resections with an intact larynx, we'll divide this reconstruction issue into 2. The oropharyngeal resections with an intact larynx, as you're seeing over here, 2 large resections. By and large, our go-to flap is the ALT. Essentially, that does not give us a functional outcome, as all of you know, but it helps us just provide form, might or might not provide function. But in diseases like this, we are typically looking at providing form and thereby trying to rehabilitate function by the things that we discussed. When we talk about an incorporated larynx in conjunction with oropharynx, then we have a specific reconstructive protocol. And some of you might consider this differently, but these are the 3 flaps that we typically use. We don't use visceral too much, and I think I'd be candid in admitting that our experience with the jejunum has not really been that much for us to utilize it very, very routinely. I know the Tata people and the HCG people have done a fair bit of work on that, but these are our 3 reconstructive options. For the most part, tube reconstructions will get an ALT, and patch reconstructions will either get a radial or an ALT unless there are severe comorbidities, which we assess on the NSQIP, the American College of Surgeons NSQIP scoring. We do have a significant data set on patients who might require preemptive salivary bypass tube insertion, as you can see in the picture on the left. That is a radio-opaque SBT. We use it in these 3 conditions that we pointed out, and we presented our data at the Academy meeting in San Diego in 2016. At that time, we had 104 laryngopharyngectomies that we looked at. Currently, we have more than 150, and we'll probably be sharing that experience very soon. So, in terms of issue 2, we talked about dysphagia, and of course, the biggest reality check was that there is no surgical tool, and there's no surgical tool which helps us obviate dysphagia after we've resected an oropharyngeal cancer. Essentially, the tools are compensatory, the tools are maneuver-based, the tools are consistency-based, but hopefully with some neural stimulation and some other devices that are on the horizon, we might be able to get further. But currently, it's a thing that we've only been mildly, if only variably successful in. Moving on, we promised you an issue with reconstruction, so we've discussed that, but there's also an issue with access. Remember that all head and neck cancer surgery, more so oropharyngeal cancer surgery, is going to be associated with 3 key steps: the approach, which is the access, the resection, and the reconstruction. This is an image from today's clinic. I asked one of our fellows to click that picture because I really wanted to add it in time so that we could discuss it. This is a patient who required a mandibulotomy for a recurrent oropharynx cancer resection. Eventually, the mandibulotomy site got infected despite the fact that he had good bone-bone union. The patient, of course, had preemptive radiation therapy, did not have re-irradiation, did not meet the criteria for re-irradiation. But after radiation, he had a resection, which you can see in that silhouette of barely perceptible lip split incision that you're seeing on a mucosal aspect. Now he has dental crowding, and he started off with this. And of course, we had no option but to remove the hardware. The bone is still healing. It's been a month or so since he had this problem. He now has a submental fistula, which will, of course, be reconstructing. But how do we prevent this thing from happening? It's been about a few months since he had his last surgery and a month since he's had this problem. Very briefly, we'll talk about mandibulotomy and the technical perspectives that are relevant to it. And at the same time, we'll allude to the images on the right and talk about how we do it. Over time, we've realized that a mandibulotomy is best done when you can combine it with a lip split over the midline labiomental crease. We've seen over time that the facial contour of most Indian patients is not very prominent. In the US, during my fellowships, I learned or grew up trying to preserve the incision through the ipsilateral labiomental crease, because that used to make the opposite chin sensate, because there is some cross innervation of the mental nerves. With time and with experience, and we now have more than a decade of experience with our patients, we realize that the midline is the best. So we use the midline labiomental crease, and that will be my take home to you. Do remember that you don't need to extract a tooth for any mandibulotomy. The roots of the lateral incisor and the canine are naturally divergent. The problem with removing a tooth prior to a mandibulotomy is that you're starting another hypoxic focus, which will not only be a harbinger for ORN. And Parin told me specifically that we're not going to be talking about radiation-related complications, and I look forward to that seminar when it's actually talked about. But just alluding it to very briefly, we don't extract teeth prior to doing a mandibulotomy unless it's absolutely mandatory. Yes, you can do a mandibulotomy through an edentulous part of the alveolus, but even that is fraught with hazard. With time, we've realized the following things, of course. A very basic point, some people start raising a lower cheek flap and really do a lot of subperiosteal raise. The thing that you're seeing at the picture at the bottom, this is from yesterday's OR. You can see the root of the canine really coming down to this level. So your stair step mandibulotomy really becomes more inferior. You maybe want a centimeter in this area, but not beyond that, so that you can get one load bearing plate up bottom and one load sharing up plate up top while avoiding that canine root. That's all the subperiosteal raise that you need. You do not need anything more than that. And using this approach and with raising subperiosteally only as much as required and with a paramedian stair step, you should be able to preserve both mental nerves, which is a functional correlate, of course. You maintain a mucosal cuff on the gingivo-lingual aspect if tumor considerations permit. For the oropharynx, that's easy. And we'll talk about extended approaches of the mandibulotomy as well in just one slide. But for oral cancer, that might not be the, but since our purview is oropharyngeal, you will be able to maintain a mucosal cuff virtually every time because the epicenter of the tumor is in the oropharynx. We talked about this already. We don't prefer the lateral mandibulotomy for access, and the exception to it would be TMJ pathology and a subsequent inability to swing. So if you need to go to the lateral oropharynx and you're trying to use a paramedian mandibulotomy, you first need to rule out whether or not the patient will be able to swing the mandible or not after you do the mandibulotomy. Just some aspects, and there are so many more of these. But again, we are firm believers in the visor flap. And just another teaching point to the early practitioners of head and neck oncology, that it's possible to do a mandibulotomy without a lip split as well. You can combine the visor approach. And this is a paper that I encourage all trainees to read, the very old paper from Neil Futran's team. In fact, that's how I first came to know about Neil Futran. He's the University of Washington, was the chair for a while. And he's also been the mentor to one of my mentors in my first fellowship. So try to avoid a lip split. I believe most of our experienced proponents would agree with that. And sometimes, if you don't really have to go very posterior, a lip split might or might not be indicated, especially in this patient where the tumor was ending there and there was no lateral or posterior pharyngeal wall extension, as you can see the radiology images. Of course, if you need greater exposure, you go with this approach. But remember that since we're talking about complications, the biggest complication in the labiomandibuloglossotomy approach or extended Denkers is that you need to be able to preserve both lingual arteries. So this hemitongue and this hemitongue, as it diverges in the middle, should be able to preserve lingual arteries. Here you can see something we burnt our fingers in. The right hemitongue is not vascular currently, and the left hemitongue, you're still getting bright red blood. That's an issue. While putting up these images, I was working on this in the morning today. While putting up these images, I was feeling a little depressed, but then thankfully today in the OPD, another patient showed up who was a panpharyngeal resection with a neck reconstruction. So he had a tubed ALT and another big ALT skin paddle came outside. And this was another patient. This was about 3 weeks back. We did a labiomandibuloglossotomy approach for panpharyngeal access. Remember, this offers you the widest exposure for oropharyngeal cancer. And here you can see the reassuring bilateral hemitongues. And this is this patient, fully vascularized. And this is what you anticipate. And in a recurrent setting, you're fairly okay with that. But remember, if you violated a lingual artery while you go posterior, especially in this tumor, we really have to diverge all the way back. It might be a challenge. So you want to check vascularity right at the end of the surgery to make sure whether your reconstruction needs to incorporate that as well. So this is an extended mandibulotomy, which typically would have quite promising results because the lingual arteries are always robust, regardless of whether they've received radiation or not. But another point of caution when you're really going to do the extended mandibulotomies. When you're able to get most things right, of course, this is what you anticipate, a small tumor, but a non-squamous histology. This was an adenoid cystic carcinoma of the base of tongue. And this can generally be very well approached with the margins that you need in salivary gland histology. And you're able to see the neurovascular pedicles that are preserved as well. And a thin radial forearm free flap, which this young patient needed for reconstruction, and a well-healed mandibulotomy site. So the mandibulotomy requires some technical perspectives, which are going to be of importance when you talk about obtaining access to oropharyngeal cancers. Remember that you're not just trying to prevent dysphagia and pharyngocutaneous fistula, you're also trying to prevent some complications that are inherent to the practice of oropharyngeal cancer surgery. It was deliberately that I put up that last young patient at the end because in the age of TORS, this case, the adenoid cystic carcinoma, was a few years back before we became a robotic center. But every single time before we became a robotic center, subsequent to my training, I always used to wonder if we had a robot or if the region had a robot, we'd be able to do more justice to it. Having said that, issue 4 and the last issue we'll talk about before we wind up, I really hope I'm not too much over time and hopefully we should be able to carry this forward, but this should only take 5 minutes. Issue 4, of course, is treating your patients with surgical organ preservation or non-surgical organ preservation. The arguments on the left are the arguments of our non-surgical oncologist colleagues, and the arguments on the right are the arguments that all of us give who believe in robotic surgery for oropharyngeal cancer. Remember how that started was, it's ironic that I'm using it in a seminar that is going to talk about complications. But ironically, we started extrapolating TORS and oropharyngeal cancer because of a complications meta-analysis. We talked about the MACTAE study, and everyone talks about it, especially the proponents of robotic surgery, about the 43% risk of 6 months toxicity of concurrent chemoradiation, and therein we should use the robot more often. But remember, there's a significant set of complications with TORS as well, and we'll talk very briefly about it and hopefully give you another reality check before we wind up. Remember that there are specific criteria for patient selection. We've now done about 55 of these, and we have to understand contraindications. A good paper, again, for the early proponents of TORS or the early practitioners is Weinstein's paper from 2015, in which they divide the contraindications into patient, into oncological and functional. But having said that, well-lateralized oropharyngeal disease is typically considered a good candidate for transoral robotic surgery. When we looked at complications, of course, there's not that much data, and there is some data forthcoming. And these are a couple of multi-institutional studies. There was some initial data from UPenn in 2007, which developed this approach, and therein it was followed by a multi-center trial, the results of which you're seeing right here, because it's complications and not sequelae. We'll talk only about trach dependence and PEG dependence. The patients who were trach dependent at last follow-up looks encouraging, about 2.3%, and PEG dependence was significantly lower as well. But if you really try to break it down, the incidence of toxicity compared to MACTAE's meta-analysis was not that much lower. So for a modality which was not oncologically more efficacious, but touted a lower risk of complications in terms of becoming a relevant treatment option, there really wasn't much data that was supporting the safety. But you'll be glad to know that we'll talk about some studies in the pipeline which are trying to address that, and hopefully we'll have much more robust data later. This is some functional outcomes. And again, remember, we're not talking about oncological outcomes. That's a topic for another day. Even though we will talk at the end about something that's very, very close to the TORS surgeon's heart. But again, talking about functional outcomes, there's something called a FOSS scale. which indicates that it was compared with the historically compared chemoradiation patients in this study in 2009, it showed a comparable FOS scale. The studies on the right indicate the crude gastrostomy utilization rates. And again, in our country, we will not call it gastrostomy dependence. We'll probably just call it enteral support dependence. A lot of our patients don't get a PEG, and some of them don't get a PEG upfront simply because we want their pharyngeal constrictors to work even during radiation therapy. This is an interesting study, relatively more recent, about predictors of gastrostomy tube dependence in surgically managed OPSCC. And the three criteria that really are the predictors of the surgical approach. And remember, this is not just TORS, this is others as well, but it's more relevant in the setting of TORS. Advanced stage disease and how much tongue was resected. Remember, we talked about at least 5 studies when we talked about dysphagia. And tongue resection is a correlate of dysphagia, like we talked about, and aspiration, which is why a lot of these patients require gastrostomy dependence to begin with. We talked about the pipeline, and we'll talk about it a little later, but this is something that's been hogging the headlines, so to speak, for the last 1 year. The orator trial. And I call this part of the horoscope phenomenon because, you know, when you read a horoscope, you think everything applies to you. So you tend to take it a little more positively. So what happened with the orator trial is everyone considered it like a horoscope. The radiation oncologist thought, oh, this is just exactly what we wanted. The surgical oncologist said, no. There are a lot of caveats to this study. So I believe the orator trial created a question that's very important to address, which hopefully will be addressed by the rest of the pipeline. Because remember, these are not phase 3 studies. These are all randomized phase 2 trials.
Dr. Samir, sir.
Yes, sir.
So we are little overshooting our time. So
okay, great. So we'll wind up in 2 minutes, okay?
Yeah,
so the MD Anderson dysphagia inventory, again, what brings to question, we talked about the MD Anderson dysphagia inventory, but the problem is it's not a head and neck specific screening tool. And we've looked at that in our own series, even though it was oral cancers, but the main conclusion, which we presented at Arizona in 2017, was that there was the need for a directed head and neck specific screening tool for dysphagia. So we have questions about MD Anderson dysphagia inventory as well. I believe that the biggest complication is a positive margin, but in the interest of time, we'll go over it. And if anyone is interested, I'll be happy to mail them this presentation. So margin positivity in TORS is a big thing currently, and there are systematic reviews and meta-analysis now. But coming to the pipeline, this is what we have in store. The PATHOS trial, which looks at quality of life in the phase 2 arm of that, as well as the University of UPenn HPU positive trial, should be able to assess adverse events at 2 years. So hopefully we have functional outcomes as well, not just survival. The problem is that there's no T4 subsets. So for a population that sees 80% of tumors as T3 and T4, it is a problem. And help from upcoming evidence is not really going to be very beneficial. So preventing a positive margin, we'll just skip through this. We had a couple of videos, we'll skip through that. And there are just one thing, there are recommendations for transoral resection of pharyngeal cancer, and you should look at it, especially with regard to margins. Okay, great. So this is the last slide, and this will more be like an encapsulation of what we've talked about. So we talked about pharyngocutaneous fistula and dysphagia, which are two of the biggest problems that we face after oropharyngeal surgery. We talked about access issues from a mandibulotomy, and we talked about the new kid on the block TORS and how it measures up, but only to some extent. Remember that the relative inaccessibility compared to the oral cavity, the neurovascular more than anatomical complexity, and tumor heterogeneity make the oropharynx a challenging site to treat surgically. Do remember, like we talked about, that you might get good oncology as a result of your interventions, but functional outcomes may be disparate with oropharyngeal surgery. So you really need to assess with whatever tools you have available to make sure that you're able to really offer the best treatment option to that patient. And that could be non-surgical organ preservation in a significant proportion of individuals. The present day focus on non-surgical and surgical organ preservation protocols makes our job as oropharyngeal cancer surgeons challenging. And it mandates a complete understanding of disease biology, when we are going to intervene, at what point is systemic therapy required, and vascular watersheds. It's extremely important that we preserve the vascularity of the native tissues while resecting the native tissue which has cancer. And finally, just like all of us do in our MDTBs, just like all of us do in our DMGs, a multidisciplinary emphasis on treatment planning could potentially give you remission as well as oncological outcomes. and functional outcomes. Thank you so much for your attention. I apologize, Parin, I went a couple of minutes.
It's okay, sir. After the truly eye-opening session by Dr. Shamit Chopra, it is time to have some little more information regarding this. For that, we have the panel. And for the lot of trainees, there are certain real-life situations that cause a great deal of the distress and frankly leave them the short of answer for the management. For this reason, we welcome Dr. P. Arun, the moderator for the panel on the prevention and management of the oral and oropharyngeal complications, real-life situations. Dr. P. Arun is a professor, senior consultant, head of head and neck surgical oncology department, Tata Medical Center, Kolkata, West Bengal. Every panel discussion is enriched by a to and fro between the expert and moderator and panelists. To that end, we are fortunate to have the different panelists. I welcome Dr. Devendra Chauka, sir, professor and head and neck oncology division, Tata Memorial Hospital, Mumbai. Dr. Surendra Dabas, Senior Director, Head of Department Surgical Oncology and Robotic Surgery, BLK Institute, Delhi. Professor Dhairyasil Sawant, Senior Consultant Surgical Oncologist, practicing at Asian Cancer Center and Breach Candy Hospital, Mumbai. Dr. Mandar Deshpande, Senior Consultant Head and Neck Surgical Oncologist at Kokilaben Dhirubhai Ambani Institute, Mumbai. Dr. Kanan sir, Senior Consultant Head and Neck Surgical Oncologist, Apollo Specialty Hospital, Chennai. Dr. Harsh Dhar, Senior Consultant Head and Neck Oncology, Narayan Super Specialty Hospital, Kolkata. And our two lecturers for the previous session, Dr. KK, Dr. Shamit, will also be joined as a panelist. Now, I welcome Dr. P. Arun sir to start our panel. Screen sharing चालू कर दिया. Sir, your audio.
Hi. Yeah. I'm sorry. Apologize because I'm not very used to the Zoom interface. It's COVID which brought me to this. And I do agree that I have joined a meeting as a panelist and somebody mistook me for a high head and neck surgeon, start firing questions at me. So I found it very easy. You just mute, stop the video, make some noises, go out and come back after 25 minutes and say there is a Wi-Fi failure. So on that note, I hope we have our panelists don't have to do that. You know, you have one of the best in the country. And thank you, Parin, for getting this great panel with me.
Thank you,
Devendra, Harsh, Kannan, Mandar, and Surendra, they're all masters in the field. Many of them have been on the scene for many years, and there are upcoming surgeons. So what a lovely mix of experience, ideas, you know, all the great things come from the younger people, and their perspectives on complications also would be different. So having said that, you know, complications are our best teachers. Wherever you train and whatever you do, eventually when you hatch out of your fellowship and as you go along your surgical path, it's these complications which will remain etched in your brain. They don't find their ways into your Facebook posts, certainly, but they do remain etched in your mind at some point of the time. And believe me, facing complications is the best education that you can have as a head and neck surgeon. I must also apologize for not bringing in a lot of topics which intuitively are important. For example, you know, pharyngocutaneous fistula, very commonly encountered, often a headache. But the treatment usually, if it does not resolve by itself, has to be in the purview of a plastic surgeon. And I think being a 6-day seminar, reconstruction would take care of that issue somewhere along the way. And again, I have reservation of the fact that I have used the prerogative of a moderator to choose certain issues which are closer to my heart. I hope the other panelists would sort of excuse me for doing that. So on that note, allow me to start, and I'll take 1 hour. And Parin, if I do overshoot time, just give me a warning and we will stop. Because sometimes, you know, things just drag on in a panel and we all want everyone to stick to time. So shall I share my screen with you as we start? Right. So here we go. Okay. Right, so that's our panel here for the audience: Dr. Devendra Chokar, Dr. Dairishil Shamant, Dr. Harshadhar Kannan, Dr. Mandar Deshpande, and Dr. Surendra Dabas. And I'll place before this panel 3 issues. Well, Christmas could be a sequelae. I just hope it remains a sequelae, because many a times it ends up as a complication. It's a price we have to pay for. I hear a lot of background, Parin, like a woozy sound going on somewhere, something you can correct from your side. Am I audible?
Yes, sir.
Okay, right. And then, TORS is no more new. I would have described this as a new boy down the street in many presentations back. But, TORS is here to stay in India. As the centers grow and people adopt to TORS more and more, we are seeing more of complications from TORS. And again, one issue is marginal mandibulectomy. So, whenever you start a talk, you use the flavors of the season, and this is the season for lockdowns. And so Christmas, allow me to start with Christmas, when your mouth decides to lock down. And believe me, whether you are a surgeon who has just entered practice, or you are that seasoned veteran with gray hair, remember that half of your patients already have Christmas when they come to, right? And when they go back, probably they still have Christmas. Maybe you would have contributed a bit to it, but eventually it remains. So what are we doing about this? Can we do anything about this is the question before the panel. So preventing trismus following oral surgery. So as head and neck surgeons, every time you cut mucosa, I'm sure the back of your mind, you have this issue in mind, that at the end of the surgery, a patient should be able to open his mouth, eat well, talk well, keep his mouth clean. So any tips from the panel? See, I leave it open at this point of time. Is it okay? Do I have to direct a question to anybody in particular? I hope not, Parin. So anything from your long surgical. Yeah, Devendra. Yeah, I heard your voice. Hi, Devendra. So what comes to your mind when you're operating this a patient before you? Not too much of trismus, but you're worried that you may give him trismus. What do you do?
So I'm glad you put up that figure of
somebody.
60. Yeah. So I'm glad you put up that figure of 65%, because we also reported our results. And if you look at 6 months down the line, majority of the oral cancer, up to 70-75% of your patients will come back with trismus. Different definition can vary, but generally taken as less than 35 millimeter of mouth opening. So most of your patients will have trismus, and this is because of extensive resections, and usually bialveolar resections have more trismus. Of course, you take care in putting in an appropriate sized flap. That is the first thing that you do. Prevent infection, and most importantly, you can never prevent trismus, but you can decrease the trismus by starting mouth stretching exercises early and continuing it through radiation therapy.
Thank you, Devendra. Great point. See, you cannot prevent trismus, but you can reduce trismus. And Devendra sends in that putting in flaps, reducing infections, and maybe putting the patients through a regimen of exercises. Devendra, do you put them through this regimen before you take them up for surgery, or is it immediately post-operatively?
So all your rehabilitation ideally should be begin before surgery, because that gives you time to assess the extent of problems, be it swallowing, be it trismus, be it any problem, dental problems. All your rehabilitation should start before surgery, and we majority of the time make the mistake of starting rehabilitation late, which should not be done. So a patient should be aware of the rehabilitation need that he has before surgery.
Great message, Devendra. That's absolutely clear that, rehabilitation measure, the patient should ideally be exposed to the way because he's more receptive before the surgery rather than after that. And the benefits are definitely more if you induce these patients to get into an exercise regimen before the surgery. Any other views from that? Mandar yeah, Mandar, are you there? Can you hear me? Yes,
Yeah.
Mandar. Yeah. Many years, you must be seeing this day in, day out. Tell us, Mandar, how do you tackle this issue?
See, I feel what is most important is anticipating, in addition to what Devendra said, is anticipating where you are going to get a trismus in the post-operative period. So obviously a patient who has a trismus pre-operatively, you will obviously anticipate. A patient who has a submucous fibrosis, you will anticipate. But where you are going to do an extensive resection, then patients, wherever you are going to handle the muscles of mastication, and where two situations specifically where you don't anticipate trismus but you get trismus is where you're going to do a maxillectomy, where obviously you're going to resect the pterygoids and where you get trismus. Second, even in major glossectomies where you're going to go and going to the areas of the medial pterygoid where you're going posteriorly, those are the situations where you are going to major resection you're going to get. So these are the situations where many
great message from Mandar there. So more posteriorly, more the chance of trismus. Don't mess with the muscles of mastication. Don't mess with the muscles of mastication. That is the message which Mandar wants to. Other issues are anticipate trismus. Patients with submucous fibrosis are going to end up with this problem. Third issue, if you're going to cut more, remove more fibrosis, more trismus. Let me go to a more younger person. I won't say definitely younger. I think we are all doing enough and more of oral surgeries here. Harsh or Kannan, one of you volunteer. Tell us, how do you do it?
So I agree with most of the things which have been told, but two issues. One is the patients who have oral submucous fibrosis. If I had to make a decision between segmental and marginal, I would go for a segmental. Second thing, I would address the trismus.
But Kannan, won't this SMF be more generalized? Won't it have, so cutting out the mandible, will it bring the adult mandible into motion?
Correct. So
I have thought of it, Kannan. I've thought of
it. At the end of the procedure, I should have a mouth opening of 4 to 4.5 centimeters. So if by removing the mandible, if by doing a procedure on the one side, I would also look at the other side. If the submucous fibrosis is there, I would release that as well. Second thing, after releasing that, I would try to reach a 4 centimeter mouth opening, and that would also be covered with a vascularized flap.
Lovely. Thank you. I think Kannan's message is that optimize mouth opening. If you have a patient on the table with trismus, optimize it. Open it up before you close. Shall I take that message?
Yeah.
Kannan?
Yeah, yes.
Okay, great. Now let me come back to my next question. Again, Devendra mentioned it. Put flaps, right? So just I want a view. Dr. Dhairashil Sawant, what do you feel? Primary closure grafts versus flaps? Which is better to prevent trismus?
The best option is obviously putting in tissue which is vascularized. There is no substitute for that. And as much as possible, whether you're doing a FRAF, you're doing an ALT, with or without mandibulectomy, with or without maxillectomy, tissue which is vascularized has to be put in. It is all right for small defects to say that, we put in a small graft or you put a partial thickness or a full thickness, but that's really cheating yourself. I think ultimately down the line, post-op, post-radiotherapy, these patients are going to end up with some sort of a trismus and a decreased mouth opening. So a very well.
And the reason would be less fibrosis. Dr. Sawant, sorry for interrupting you. Would be less fibrosis if you put in a vascularized tissue there.
Yes, absolutely.
Thank you so much.
You can put a nasal label. You can put a nasal label, but that's again a good tissue to go in.
A flap. That is again a flap. I get your point. I get your point. So these are some pictures. This is a buccal pad of fat. So this is almost like a primary closure, or maybe the fat is there, so you pull in and you call it a flap. I think it's primary closure with the fat around it. It's healing by secondary intention. Sometimes you get very bad trismus with it, but sometimes, like in this case, just for this little fibrotic band, there is nothing there. Again, look at the skin graft.
Dr. Arun, if you
tell me, yes,
patients, they end up with more trismus. If this is a small lesion, you may not be adding radiotherapy. They'll do very well.
So radiotherapy, I get your message again. If you add radiotherapy, that is again injuring your tissues. This time with gamma rays, but not with your surgical blade. But again, radiotherapy is injury, and injury heals with fibrosis and causes stress. Skin grafts. So many, when I started my career, we were a big flap center, very fond of flaps. And then, and reality strikes when you work in areas where everyone can't afford flaps. We started putting in grafts, I was blamed. Grafts contract, they cause trismus. But look at this lady, they do. I'm not saying that they don't, but there is something more to it than grafts and flaps, right? The healing is good. The skin is sitting on the bone, does not need pre-prosthetic surgery. We can give in a prosthesis straight away as soon as this graft heals. So there is something more to it. But I believe the thought is that
the bed
so there is more to it, that putting vascularized tissue definitely reduces fibrosis and probably could reduce trismus. Now comes another issue. You have patients, the other half, who have gone home coming with established trismus. Again, Dr. Devendra, people all over the world operate and send them over to you when there is no go. So you must be seeing a lot of these patients with trismus. Well, Dr. Saab, do something for me. And as surgeons, we usually think surgery. So Devendra, what do you do? Do you operate on these patients?
See, first thing, Arun, that you have to what the onset of trismus. Has it been there since surgery, or is it recent onset trismus?
Great.
Because sometimes the recent onset trismus can be because of a recurrence of disease in the infratemporal fossa or involving the muscles of mastication. So important point is to rule out recurrence first, and then look at the trismus, whether the patient has completed treatment. So generally these problems are very difficult to treat, and you have to also look at what kind of reconstruction was done first. So if it was inappropriate reconstruction, inadequate reconstruction, then maybe you can release the duration of trismus. If the muscles of mastication are already gone fibrosis, there is very little you can do to treat this trismus. So all these points must be kept in mind. And if it is inadequate reconstruction, you can maybe go in and release trismus, but the results are not as good as submucous fibrosis. I know the submucous fibrosis results are nowadays with the nasolabial flap are quite good. But post-cancer surgery, where the muscles of mastication have taken a beating, with surgery and radiation therapy, the results of redo surgery are not the best.
Wonderful. Thank you, Devendra. Great messages. One patient comes with a trismus which has developed later. Rule out a recurrence. Look at what reconstruction has been done. In spite of putting flaps, in spite of putting thick ALT or even muscle flaps, you would find that after radiotherapy, fibrosis does set in. And in these situations, you will have to think of surgery. And again, as Devendra put in very, very correctly, it's not always a band release. It's not always a band. It would help. It depends on the nature of the trismus. Why did it develop? Is it mucosal? Is it muscular? Is it because of a TMJ issue? It's very important that every trismus patient be analyzed, or each patient be seen in a particular light before you plan surgery. I'll just move on to anybody. Yeah, please go ahead.
So like we have an entity called
Harsh, I was waiting for you. Yes, sir.
Hi, sir. So we have an entity called reflectory trismus.
Right. Refractory or reflectory? I didn't get it.
It's a neurogenic. Yes, it's a neurogenic thing. So I think one very important thing that we need to rule out is the pain management in the post-operative period as well. So recent onset pain that can reset a cycle of reflectory trismus. That is something that needs to be looked into. And so just one more thing, like as you have on your slide, like injections, steroids, Pecentrix. I know that there are many practitioners, general oral maxillofacial and even ENT practitioners in the community who use a lot of these.
Do you feel their work? Harsh?
There is a Cochrane review. Absolutely. No, sir. We have a Cochrane review to support that there is actually no increased benefit of using these agents.
Right. So anybody who, I just want to see whether, operate, what would be your surgery? Quickly, can we go down, do you operate? Dr. Dhairishil, any of these surgeries, what do you do most commonly, or you don't do anything at all? Give us some message.
Going from simplest to complex, simplest would be a nasolabial flap, even a submental flap, or then going on to radial forearm, either unilateral or bilateral.
So a flap would be your choice. Interposition flap would be your choice, and from the simplest to the most difficult. Yes, great. Kannan, anything?
Whenever there is no recurrence, I would think twice before operating on a patient with trismus.
Yeah.
I don't know. I have a point about.
Yeah, KK. Go ahead. Go ahead, KK. Oh, sorry.
I think we didn't discuss about coronoidectomy. Will it
wait,
help?
wait. It's coming. Yeah. Okay. You do. Go ahead. Let us go ahead. Go ahead, KK. Okay. Coronoidectomy. Yes.
Coronoidectomy. I have a question.
Yeah.
We do coronoidectomy in most of the cases of trismus, but will it actually help? I want.
Yeah. Wait a minute. So, come again. Many times we get to these meetings, we see lovely, sexy pictures, pre-post, a millimeter going to 10 millimeter. Tell me, long term, let me put this to Dr. Sawant once again. Long term, say 6 months after you have put in a flap, what percentage, or maybe just give us a ballpark figure of results from interposition flaps? You find it good, not so good, varies from people to people.
So answering partly what Dr. Thankappan said, I think we, even for maxillectomies, if you are not touching the mandible, I would still go ahead and do a coronoidectomy.
Right.
And there is easily about 25 to 30% decrease in the oral cavity this after maybe 6 months to 8 months. So we really like to put in a nice good flap. Which if you think that this was very severe, a nasolabial also may not work. You might have to put something bigger than that.
Yeah. Anyone, Mandar, some views on surgery for treating established trismus, your experience? Surinder can pitch in.
See, if I'm doing a trismus release as a primary procedure, I'm not saying a redo kind of. I'll be very reluctant in doing a redo procedure. But as a primary trismus release, if I'm doing, first I'll do a mucosal release and see whether it depends upon how the mouth is opening. First, I'll do a mucosal release. In spite of that, if the mouth is not opening, obviously I'll take a deeper cut. Then I'll realize if the mouth is not opening, I'll go down and either I'll do temporalis myotomy or I'll do a coronoidectomy. In a maxillary,
basically release. You don't put flaps, Mandar.
No. And after that, obviously the defect which has been created has to be covered by a flap.
Okay.
And there are two procedures. One is to release procedure and second is to put in a flap.
Okay,
great. In a maxillectomy, I'll always do a coronoidectomy because that helps in both preventing a trismus as well as it gives me access to a maxillary artery, and that's the reason why I'm always doing a coronoidectomy.
So none of you use injections, steroids, Placentrex? There's a lot of papers and huge data out there on all these stuff.
See, even if it gives a temporary relief, there is always a kind of a refractory, there is a rebound phenomena which is there.
Fine. So let me sum. Go ahead. So let me sum up.
Arun, can I just come in one point?
Yeah, sure, Devendra. Please do.
So, I agree with temporalis coronoidectomy and temporalis release, but you must keep in mind that you may still get trismus because trismus is because of muscles of mastication, and temporalis is one of the muscle of mastication.
Correct.
So, the pterygoids also will fibrose and give you trismus. So, there have been papers in marginal mandibulectomies where they looked at the release of the temporalis and release of the pterygoid. So, just by doing a temporalis release, you may be sometimes disappointed and still get trismus.
Yeah. Yes, great. Devendra's argument is that it's the masticator muscle complex that decides how your mouth opens and closes. One muscle may not change things, right? So that is Devendra's contribution. And again, I haven't seen long-term results. So this is something we can all work on, think about. If we do all these kinds of things, many times we are pushed by empathy. Many times we are pushed by the patient's pressure. We do these procedures, but what happens to them in the long run is something we don't know yet. SMF, somebody brought this issue, and this is typically a subcontinent issue, right? What is the general feeling? Good, bad, ugly? Devendra.
Yeah, bad for the surgeons.
Bad for the surgeons and as for the patients as well. Dr. Sawant, Harsh, Kannan, what do you feel? SMF is an issue?
Oh yeah, definitely. Even if you have done the best thing on one side, you have to do something for the opposite side. If you have
Kannan. Yeah. Kannan, you said something. I just heard your voice. Kannan?
No. I agree with
bad, right? You agree it's bad. Harsh?
I think one very important point with this thing is the access to the primary tumor. Sometimes even that is impaired during primary surgery.
Right.
Especially if you have a large tongue going posterior, access to the primary tumor also gets affected if you
Oh, wow. I'll take this up. I'll take this up, Harsh. Great point. Okay. Now comes the issue. Many oral cancers get radiotherapy as well. And here it's not the mucosa which you cut or the muscle you get. It's a field which is burnt, right? It heals with fibrosis. And it would usually be the muscles of mastications that the stricture or contracture or fibrosis that would cause it. And these situations, you all have been talking about coronadectomy. Krishna Kumar, again, let me put it. If it is a mucosal band, if it is just limited to the muscle buccinator and a small cheek excision, would you go and do a coronadectomy? I would do this procedure mostly if I'm doing a salvage. And usually these patients have severe trismus. And I know that the muscles of, again, coronoidectomy only releases the coronoid. It does not release the lateral or the medial pterygoid. So Krishna Kumar, your views on this. Would you do coronodectomy for all, or would you select your patients to certain situations? KK?
Yeah, yes, I don't know, I heard you.
Yeah.
Obviously, I'll probably reserve coronodectomy for more severe trismus. In minimal trismus with only mucosal bands, I may not do coronodectomy. Yeah.
Lovely, lovely. So great messages, beautiful. That, trismus an issue, surgery is there up in every surgeon's mind. There are, since a lot of options, probably none of them work very well. Flaps are considered to be the favorites. Your surgeons would want to put in flaps so that, obvious reasons. We are putting vascularized tissue, anticipating less fibrosis. Probably radiotherapy may undo whatever you have done with the opening up the mouth. Like Kannan said, optimize trismus, open up every time you do an oral surgery. SMF causing trismus is a major issue, and surgeries like coronadectomy may be considered, but again, we do not know what the long-term outcome. But I think you would all agree to one thing, that the sheet anchor, the key treatment for trismus, still sort of hangs around two things, like devices and exercises. KK showed us a snapshot of the devices that you go through. Again, I'll just pass it across the panel once again. Anyone? Dr. Devendra, Shamit, Harsh, Kannan, Mandar, Surinder, just pick up the phone. What would you choose? What would you choose among all these?
We use the Orabyte or the Terabyte. The Terabyte is the US one. The Orabyte
yes.
is the Indian one.
Great. So preference, why do you want the Orabyte? They are expensive, right? You see cost there as one of the points noted.
Yeah, but Orabyte is cheaper. It's about 4,500. So it's okay. It's not as expensive.
So yeah, so you mean to say we have an Indian version of that which exactly resembles the Terabyte, right? Which, yeah, and probably. And what is the advantage of this? Can you tell me what is the advantage? That is Devendra, right?
It does mechanical pressure thing and it is quantifiable. You can tell a patient how much, and the patient also feels that he's doing something which is showing a quantifiable result.
There is may I put it like that? There is a feedback. So you see that there is a scale by the side of this, which will give the patient a feedback, and that is quite encouraging. So if you achieved 5 millimeters today, went up to 7, that will sort of motivate the person to try better, right? Great point. Anybody else? Let us see.
Can I make a point?
Devendra. Yes, Dev. Yes, go ahead.
So, we've looked at Orabyte.
Shamit, yeah.
Yeah. So we looked at Orabyte, and we also looked at a regular Heister or a wooden block. And so far, we've not found a difference in the degree of improvement. Remember that the absolute increase in interincisal distance is not what we're looking for. We're looking for a relative increase. And as someone pointed out, seeing these patients routinely through the course of their radiation therapy, if mandated, would be the most important step. Because once radiation sets in, as you pointed out, once those fibrotic bands are formed, then regardless of whatever you do, the results will be unpredictable as the variable.
Not a fan of Terabyte. I agree, Shamit. Who else? Let us say, KK, what do you use as a common thing in your OPD? You do give these things, I'm sure.
Yeah, mainly depends upon the cost and money part.
Cost and money. Great. Cost. My third point there. Correct.
Terabyte is the best.
Terabyte is the best.
Lasts long. And the problem with the what is the steel instrument? what is its name? I'm forgetting the name.
The Heister.
Heister device. Heister device. That the pressure is going on to only unilaterally. Okay.
Correct.
It's not getting the the uniform pressure on both sides. So if there is a flap or a mandibulotomy or a plate, if you are not using it correctly and at correct timing, the healing may be affected and that the joint may be.
Awesome. Thank you. Thank you. Dr. Savant, your choice?
So as I said, if cost is not a consideration,
Terabyte. Orabite. Let me put as Orabite, which is the Indian version, which is much cheaper than the original Terabyte. Mandar, Surinder, yeah, tell me.
Yeah, sir.
Can you hear me?
See, I'm not able to recognize you from your voices. So, is it? I can hear someone. Yes, go ahead.
Surinder.
Yeah, sir.
Surinder, go ahead. Surinder, go ahead.
So,
Hi.
I said.
Yeah.
What I want to say was, Dr. Samit has already spoken
about
the coordination between a surgeon and radiation oncologist. That
right.
is very important.
Great.
Because most of your patients get trismus once you have done a good surgery. There's a good mouth opening. But after surgery, patient is going for radiation therapy, and I'm sure 90% of radiation oncologists never advise mouth opening exercise.
Okay.
They don't go
yes.
for it.
Exercise. Your emphasis is on exercise. Regular exercise rather than anything. Great. Absolutely. Good message. Great message, Surinder. So again, we have heard all our panelists.
Arun,
basically, yes.
Arun, Mandar here.
Mandar. Yes, Mandar. Go ahead, Mandar.
Terabyte is definitely good. Why? One is because it distributes the pressure all across the teeth. Second thing is that it is padded. So it is because during radiation and after radiation, the teeth become very sensitive, and patients are reluctant because the metal, the histers and all are metal, and the teeth become very sensitive post radiotherapy.
Get you. Dental trauma. My second point is what you want to emphasize there. Right?
Yes. But the cost is so exorbitantly high, especially the Terabyte one. Even the Orabite is more expensive compared to.
Got it. So let me sum up. For the entire panel as it is. These devices are there. Some are cheap, some are expensive. For the expensive ones, there are Indian versions of it. Probably haven't gone through regulatory authorities, forget about it. But anyway, we are not going to implant them. So they are useful. Now, the advantage of the Terabyte system that it has been here for some time, it puts the pressure across the entire arch, and rather than putting it at one tooth or one side of the mouth, whereas Krishna Kumar said probably it may be inadequate, or if you put it on one tooth at all times, maybe it would cause dental trauma. The other ones, like the wooden screw, has a similar issue. There is a friction, and very soon it can damage your tooth and cause dental sensitivity. So we don't have an ideal one yet. So depending on the patient's ability to pay or buy, again, compliance is a big thing. If there is pain, dental trauma, there is sensitivity, they are going to stop using this, right? So compliance, and one way of ensuring this is to give the patient a feedback. And one of our panelists actually pointed out that the Orabite/Terabyte devices have a scale on that, which will give a positive reinforcement as we go along. So thank you so much for that. So what is the evidence there? We have discussed so much about trismus, right? And this is, again, as Krishna Kumar said, this Dijkstra is the person who is the man who writes most about trismus. He has spent his entire life doing it out. None of the modalities are effective. No extracts, no laser band release, flaps. So again, these are systematic reviews. This is already published literature. You glean data from that and bring out your own data. Only 4 studies out of the so many actually qualified for that. So you can't say that the last word has been said about trismus. Like even basic issues like, how do you define? Devendra said 3.5 centimeters. There are many papers which measure it with a finger definition. Where do you measure it? Inter-incisor, right? If there are no tooth, where do you go? Duration of follow-up. Things look beautiful in the first few weeks, and then your enthusiasm begins to dip. Again, it did point out, this systematic analysis did point out of certain issues, that exercises Kannan said, I said, or during radiotherapy, continue exercises, or Surinder said that continue exercises during the radiotherapy. Tongue blades are beneficial if tooth regularly. Microcurrent treatment, there is only one paper. I didn't find that there is enough evidence yet, even though this has been mentioned in the systematic analysis. Pentoxifillin again, but any of these interventions done on a short term has no benefits on trismus. So again, my view on that the management of trismus needs to be tailored to its etiology. It's not that a band release will help every time. It's important to determine if the condition is a consequence of pathology in the muscle, in the mucosa, the musculature, or the bone. Sometimes you may have to do a coronadectomy, you may have to do a condylectomy. Tissue healing characteristics are as important. You may put in the biggest flap, but if the tissue healing is bad, there is fibrosis. Even flaps are going to, now you find patients with huge flaps coming in with trismus. And of course, your surgical technique is also important in determining these outcomes. Exercise remains the mainstay for treatment as well as prophylaxis. Of course, flaps have local, free flaps have proponents, even evangelists. But let me tell you that hard data is yet to hit home. So with that, we move on. Maybe a practical issue. I just borrowed this.
Small
Go ahead. Go ahead, KK. Go ahead.
I mean, it's always a practical question which comes from the patient. Doctor, I start doing this exercises and it's very painful.
Yes.
How do I proceed?
Go ahead. Panel, great question. Pain is an issue. How do we do? Now, KK, you need to say, is it from the tooth or is it from generalized pain?
I mean, it comes from that RMT area.
RMT, when the muscles stretch, there is pain, right? Right.
I think one important thing we need to...
Harsh there, right? Harsh, go ahead.
Yes, sir. So one important thing we need to rule out when we initiate these exercises is to look for malocclusion. Many of our patients during the course of the treatment, or because of the flap, even after radiation, when they are there for follow-up, we need to look at the issue of malocclusion, whether that is there or not, and that is something that needs to be corrected. Because if we initiate exercises for a,
correction of occlusion can reduce pain is Harsh's contention, right, Harsh?
Yes, sir.
Go ahead. Right. Anything else? Anything else? KK, any solutions? What do you do?
I usually give some analgesics and
analgesia.
But they are not very happy always.
Yeah, the problem is again, constant. Many patients have come with loose teeth after putting in that metallic device without, even with a rubber bush on that. The teeth with constant, it's not an immediate trauma. It's a long-standing trauma. You keep pushing, it's like an orthodontic treatment. The teeth slowly begins to move out of place. So again, not a great solution. So let us look at this patient. Obviously, look at him. Arun, he has trismus. Oh, go ahead.
Arun, this is Kaustubh here.
Kaustubh, yeah.
I'm not a panelist, but I just wanted to make a small point, which is a basic point, which we have not yet covered into the trismus management. And that is what I wanted to raise for the trainees and the surgeons, the resection surgeons.
Sure.
Now, most of the time when we do resection surgery and we leave it to our plastic surgeon, we move out, we forget to see that how they are suturing their flap, how the flap inset is being done.
Right.
Many a times I go in, I see to it that the flap inset is entirely done with the open mouth. This is a basic thing which has to be there, which has to be ensured that the entire flap is sutured with an open mouth. Right. Because whatever flap you are doing, if it is sutured with a closed mouth, it is bound to create a trismus.
So that is a
basic point.
That's a great point. And you realize it when you are a reconstructive surgeon as well, right? But for those, like if you, I agree, most centers, we cannot do that. In busy centers, it has to be a two-team approach. And it takes a while because they don't see or sort of appreciate, their worry is only about the flap viability or livability rather than what happens 6 months down the line. So thank you, Kaustubh, for bringing that up.
And these patients are seen in follow-up by you only.
Correct. Absolutely. Thank you. Great point. So here we have a 42-year-old male, again, carcinoma tongue. It was on the left side, was radiated a year back, as usual, went back to his habits. Now we have a growth on the right side. and there are fibrotic bands on either side. SMF probably. And clinically, you can just peek through that little window where his teeth have been extracted, and you see an ulceroproliferative growth. Harsh, since you raised this issue, right? There are no palpable nodes. I can't see what the size is, stage. I can't put in a finger. Probably, I don't have thin enough fingers to put in through that gap. I can't palpate. I don't know what the size or stage. So usually, like all surgeons, what do we think of when we see a growth? It's a biopsy. Tell me, Harsh, how difficult are these situations? It's a recurrent tumor on the opposite contralateral tongue, and now he comes with another growth. Now there are these jagged teeth in the front, right? He has received radiotherapy, and there is an ulcer now. So again, back of your mind, you're worried. Is it cancer? Is it not? It's only 1 year since he had an early cancer. So how will you proceed? Give me your thought process.
So I think these are the kinds of situations where just more than the clinical examination per se, we need to rely a lot on the screening modality and on the scans. But having said that, one thing that can help one in the outpatient clinic is using an angled scope. In case you have some little bit amount of space, you can use a thin scope, and you might be able to visualize your lesion. But that is more often than not, that is very difficult.
But then you are not palpating, so you're just seeing the proliferative area.
Not able to palpate. So I think if your clinical index of suspicion is very high, that this could be a recurrent growth, this could be a second primary, I think, and if your examination is limited by trismus, you would go for an imaging, and based upon your imaging, for perhaps then plan the patient for an examination under anesthesia, and then probably take a biopsy in the OR.
So Harsh's plan is to go for an imaging first and then get a biopsy. What imaging would you suggest, Harsh, in such a situation? It's a recurrent disease, has had radiotherapy, probably got radiation because of adverse pathologic factors. What would your imaging be? Would it be a CT, an MRI, a PET?
So the choice here would definitely be between an MRI and a PET scan.
And a PET. Kannan, would you go for an imaging or a biopsy first? Or do you just want to at least give it a go? There is a little bit of a gap there in the tooth. You saw that? Do you want to just poke in and try to get a diagnosis before you go ahead with a PET? With these guys, you look at him, give him a PET, he's going to squirm.
Better to have an imaging before we do a biopsy.
Lovely. Any other seniors? Let's see, Devendra, how would you tackle this?
I agree with Harsh and Kannan both that imaging is very important to map the disease first, and then go for a biopsy. If you can take it in the outpatient, well and good. But most of the trismuses, you can stretch it under J, they go back to forming trismus, but you can definitely stretch it under J and take adequate biopsy. So
lovely. Any other views?
Dr. Arun.
Yes, Surinder, tell me.
So what we do is the patient who has trismus, we always do it, use a 0-degree scope.
Yeah.
And do an intraoral examination with the scope, and you can take a biopsy with the laser instruments. So do
with a laser.
With a laser instruments,
great.
Biopsy forceps basically.
Okay.
Not a laser surgery. I'm saying you can take biopsy with a laser biopsy forceps basically.
Which the worry here is back of, even though we have seen so many cases, Surinder, there is the worry to go deep in these tumors. Sometimes early granulation, traumatic lesions, they may mimic malignancy and they may induce bleeding. And if it bleeds, there is no way to pack that area as well, right? So we are also wary about getting biopsies. It can precipitate bleeding. Sometimes, haven't you had opportunities where you have to put in a suture or two in the OPD? How are you going to suture that wound? It is difficult, right? So we did attempt in biopsy. I tell you, I fully agree with Kannan and Harsh that, okay, I would have gone for imaging. See, look at this early tumor, you're going for a PET in this case, but that is what trismus does, right? And again, look at it, because I believe that it wasn't a deep enough biopsy. It just came as a foci of high grade because the pathologist was kind. They just wanted to give in a diagnosis and said it's high grade dysplasia. Imaging, yes. Any other choice? I would say, Harsh would say PET. Anyone down the line has any other opinion, or maybe even a MRI, which would be good in a tongue lesion, which is more of muscle rather than, so the MRI would define the tumor better for you. PET would give you metabolic information as well. But for anatomy, you would have to combine it with a CT and cause it a PET CT. I don't know if anyone does PET MRIs, but that would be, these would be the two options which I would put on the table. So all across, let's see. Dr. Dhairishil, what would be your modality of choice? Would you agree to what has been discussed so far, that biopsy imaging?
I think evaluation under anesthesia with an MR, and I would also do a PET, because unless, I think Kaustubh has got a facilities for PET MR, but if you don't have that, do both investigations, because it's a recurrent disease.
Lovely. So PET.
You have to be clear about what you're dealing with.
Lovely. So this PET is exactly what I did, because I found that it's a high-grade dysplasia, a patient who has already received treatment, a possibility of a recurrence, SUV of 3.89, 1.7 tumor, centimeter tumor, few nodes, and this is on the contralateral side, the non-operated side, no metastasis. We are back to square one. Can you help me here?
Arun, before, can I just make a comment? Just to
clarify. Sure.
We need an MRI for, see, when you're imaging, you need to know.
Somebody has, please, may I request our audience to mute their mics? I'm listening to someone fighting with somebody else. So please, if you can mute it, we can carry on with the discussion. Thank you. Yes, Devendra, go ahead, please.
The decision that you have to make is whether you want local imaging or local imaging plus distant imaging for metastasis.
Correct.
So that is the decision which will help you decide whether you want an MRI, you want a PET scan, or you want both. You want an MRI and a CT scan of the chest, where commonly the metastasis go. So if you have a recurrence, say 1 year, 2 years, 1 year, which is the most common time of recurrence, and no neck nodes, and you're not expecting distant metastasis, an MRI is fine. You image the local area. Otherwise, a PET CT, if you're thinking, or a MRI combined with the CT scan of the chest. So
would that be sufficient to drive you to surgery, Devendra? Devendra, would a MRI showing a lesion, again, it's only 7 centimeters, would that be evidence enough for you to take the patient back to surgery, tell him that probably you have a recurrence, or would you do an UA under GA frozen proceed?
As I said earlier, we will do an MRI and UA biopsy. And if it's high-grade dysplasia, as you said, what do you do for high-grade dysplasia? And if you combine your clinical judgment with your pathology findings, to a certain extent, to make a decision, but you must also fall back on your clinical judgment. See the tumor, see the MRI picture, high-grade dysplasia, which you would excise even if it was not a cancer. A high-grade dysplasia coming on site of previous cancer, you need to excise.
So surgery is mandated, whether it's high-grade dysplasia or tumor. You would take the patient for anesthesia, or open up the mouth, have a look at the tumor, and proceed with surgery. Right?
So one thing about the MR, so if I can just add.
Great message. Yeah.
Yeah. So with the MR, so we have the facility of the DW, the
diffusion weighting images.
Exciting data to show that, with the help of DWI, you can differentiate between a neoplastic and a non-neoplastic. That is something we can work with.
So a diffusion MRI, usually all our cancer patients undergo the diffusion weighting protocol. But again, nothing like PET, like a 3.89 is somewhere like an inflammatory thing, right? And again, I can call it a silly, useless value. People may debate over it, but it doesn't give me the confidence. So went back in again, got a biopsy this time, took a risk, thought let it bleed, we'll do something, take him to the OR if necessary. On a day when you are free, you take this biopsy, it comes as a squamous cell carcinoma. So look at the amount of issues. Look, go ahead. Who is it, please?
Mandar. Arun?
Mandar, go ahead. Mandar, please, go ahead. Mandar.
Yeah. If I'm doing a PET, basically I'm doing PET to rule out distant metastasis. I'm not doing PET for the primary diagnosis.
Right.
Every investigation which has been said, I'll do all these investigations: biopsy for local diagnosis, MRI for the depth of the invasion, PET to rule out distant metastasis.
So would your patients have both, Mandar, both a PET and an MRI, or would you do an MRI and a CT thorax? Because as Devendra said, it's only a T2 tumor to start with.
No, agreed. In a sense, I would do biopsy, I would do MR for the depth of invasion, I would do a distant metastatic workup, if possible PET, or some kind of a CT thorax at least, and EUA on table, either on table or depending upon how the logistics are, to decide on the kind of a approach for my surgery.
So Mandar, three modalities from your side: an MRI for the tongue, a CT thorax, and probably if the patient can afford, maybe a PET even to give you more metabolic information, right? Shall we go? Wow, see how Trismus has changed the way you look at a simple T2N0 or a T1N0, right? Isn't it amazing? Yeah.
So even the biopsy, sometimes you have this infiltrative post-radiotherapy tongue.
Correct.
It might be better to do a knife biopsy and take sutures and just close that thing.
Agreed.
Otherwise, all of us
you may end up with a surprise. You may end up with a surprise. You're absolutely right. Now, our problem does not end here, right? Since we got a squamous cell carcinoma, we believe our pathologists were, since it's a radiated patient a year back, it was a recurrence. So we thought, yes, let's plan for enough tongue volume left. So didn't plan anything fancy for him. A wide excision, neck dissection, and primary closure, which would be the standard of care in that. Now the question comes, how will you access the tumor? Devendra, you said you are going to do an EUA. I heard Mandar say you're going to do an EUA. How will you access this tumor? This may have been there for years. This is a very, very sort of recalcitrant trismus. What would you do? How will you access it?
So generally, these patients with trismus, you can have adequate mouth opening under general anesthesia. There is a fair amount of mouth opening that you get with general anesthesia.
Sure,
but if you don't and you can't access it intraorally very well and can't get a posterior margin, then the other better option is to do a pull-through procedure rather than fall back on a mandibulotomy, which you don't want to do in a post-radiated, 1 year post-radiated.
Great.
So it's a combination of intraoral with a pull-through.
Beautiful. Anybody else? Great message from Devendra. So don't do a mandibulotomy. If you want, you force open the mouth, release the band. If you want, open the mouth and go on with your surgery. But you may also have to plan for a drop down. Dr. Devendra doesn't want to do a mandibulotomy. Would you agree, Dr. Dhairishil Samant? Do you still agree that mandibulotomy is like
a lot of these even the glossectomies? I would rather not do a mandibulotomy, and this is post radiotherapy. So I definitely would like to try and do a pelvic glossectomy, pull it down, because the most important thing is the posterior margin in this patient, and it's a radiated tongue. So
Agreed.
It's not going to be soft. It's not going to be soft and hard. It's all going to be indurated.
You may end up with a surprise even, because its induration will be very misleading in a radiated patient. Your finger may not be able to tell you correctly, right?
Absolutely.
Dr. Arun?
Harsh, Kannan, yes. Oh, yeah.
So may I interrupt, sir?
Go ahead.
So there is one question from that Dr. Jatin Shah. Would you not operate if PET shows low volume lung mets?
Low volume or low uptake lung mets?
Low volume lung mets.
A volume will have to be sort of dealt with in its own way. If it is amenable to an FNAC from a CT guided biopsy, it would definitely be addressed. But the problem comes when you have very small suspicious looking nodules, and our radiologist finds it difficult to place a needle into that and take a biopsy from that. There, if you cannot prove it as a lung metastasis, or you don't have an ample proof, PET may give you an SUV value. India is where you have tuberculosis. So it is a difficult call on a lung. But if we feel that it's a metastasis, it can be biopsied, they would be biopsied. If not, we would, even if the SUV is higher, we would not put it as a metastasis. We would look at the general picture of the lung. Are there other deposits? Are they peripheral? Do you have mediastinal nodes along with that? Could it be there's a tree in bud appearance which they describe? If they think they could be tuberculosis, probably we will just discuss this with the patient, go ahead with the surgery and keep a watch on these nodules. Maybe if required after the surgery or maybe even before the surgery, see, bronchoscopy would be difficult in these patients with trismus. We would send them for an assessment to a pulmonologist. Does that answer my question, Dr. Shah?
Hello.
Yes, Kaustubhai.
Yeah. So Dr. Jatin Shah's question was clearly that whether you will operate or not in a low volume, lung mets. I think that is what he wants to ask.
So
Surgery of the
metastasectomy.
primary is crucial for quality of life and function,
Right.
even in the presence of low volume asymptomatic.
I would look at the biology as well. I would look at the biology as well. Adenoid cystic carcinoma, small lung mets, go on. Any other salivary gland, single metastasis, probably I would go for a metastasectomy. Squamous, single, again, we would think of it, but I would be more wary of operating on a squamous, and especially a patient who has come back within a year with a recurrence in the tongue.
Okay.
So again, so shall we carry on?
Yeah. Only thing is, Arun, since Dr. Jatin Shah is there, we we wanted him to come to the panelist side if you
It's an
allow.
honor.
I mean,
it's an honor. It's an honor.
We will try and
Dr. Shah,
update.
it's an honor.
Yeah. Thank you.
Right. So again, band release, forceful opening is something we do standard. I think we are running out of time. Such a lovely panel, great discussion going on. We are not even able to move across to the next topic, and I was a little wary that there are thousands of complications and I'm covering only 3. So mandibulotomy, there are attendance risk of osteonecrosis, plate complications, drop down, like Devendra said, would be my option. But sometimes, dropping down from the neck without, separating the mucosa from the mandibular periosteum is sometimes you get a lot of tears, you tear here and there. It's a dirty surgery, but that would be the way I would try to approach this tumor. So let's move on to the next. I think I will be able to cover only one, because we have 2 great robotic surgeons here, Mandar and Surinder, spend their lives perfecting this art, and there's so much we can learn from them as we go along. So I am limiting myself not to open oropharyngeal surgery, because the opportunity to do that are few. We used to do that when there's no other way of base tongue recurs, you have to do an open surgery. But with robotic surgery, Dr. Rajiv taking the lead at our center, we are doing more and more TORs for these kind of lesions. So TORs is like, once again, what was primarily the domain of a surgeon when it came to recurrent tumors has now come back as to the surgeon as for primary oropharyngeal surgery. Now the issue here is, I think I'll focus myself to Dr. Surinder here. Surinder,
yes, sir.
Yeah, we have seen this machine being docked. It takes time. It's remote access. So do you think, TORS is an impediment to quick intervention? You have an open surgery, you take the patient in, cut a few sutures, you are there in the field. Here, I'm a little worried, Surinder. Come reassure me.
Sir, if you ask me of the docking of the robot, yes, it was a difficult time when you started. Right. If you exactly asked me docking with the system, with the SI system earlier, it was a bit difficult. But as a newer system like XI, the docking becomes much easier now.
Yeah.
Because of the mount on the head, and you can dock your robot within 2-3 minutes.
And you feel as comfortable as putting a pack on the base tongue after you open up your sutures with your robot?
Absolutely, sir.
Absolutely, great. So that is what experience does to you, I believe, Surinder. Now, we are also worried that we would very intuitively think of a flap in the oropharynx, doing an extended tonsillectomy, using a base tongue resection, put in a flap was the teaching. And here I see you going the whole hog, healing by secondary intention. I'm worried about the airway and bleeding. Reassure me.
So now it depends upon the site which you are operating and the tumor of volume you are cutting. So if you ask me, the indication for surgery in oropharynx are very limited. It should be a small tumor like T1 and T2, and basically maybe an exophytic tumor. But when you're moving to endophytic tumors and bulky tumors like in tonsil and well lateralized tumors, you can also insert your free flap. But in that case, when you do your neck dissection, you take out the gland, make a tunnel between the neck and the oropharynx, put your flap, and you can suture 90% of your free suture by just an open technique. But sometimes you use a robotic system to suture deep down near to vallicula. But yet it needs experience.
Yeah. So again, Surinder, do I get it from you that even your message is not to leave large open areas? Try to close suture as much as possible.
Never, sir. Never.
And whether you use a robot, whether you can do it with a little sort of put in a headlight and do it, go ahead, close that row area as much as possible.
Absolutely.
Would that be your message, Surinder?
Absolutely, sir.
Thank you so much. Mandar, Mandar is again, has been into robotics for a long time. This is a study, almost 2,000 procedures, 45 surgeons, the spectrum of complications that they encounter, right? Mostly bleeding. Okay, this includes both severe and minimal bleeding. What is your experience? What would be your biggest worry when doing TORS? What are the complications that you encounter most frequently, Mandar?
See, any robotic surgeon, I would say something which any robotic surgeon is worried about is bleeding. And but I would say there are steps that every robotic surgeon has to take. I would say it starts with how to prevent bleeding, and I would suggest those who are stepping into a robotic surgery, be it a transoral or I would say any other form of robotic surgery, is you plan your surgery well. As Surinder said, never step into a robotic surgery where don't try to resect very large tumors. So it is indicated. Don't extend your indications. Select very small tumors, indicated tumors. Second thing is that you have to study your kind of images well, the proximity of the tumor to the major vascular structures. Third thing is that you must know the inside out anatomy and of these are the same vascular structures which are there, but you are not going from outside in, you are going from inside out. So you must know your landmarks well. And the way in the open surgery, you are kind of saying the posterior belly of digastric, omohyoid.
Planning, right, Mandar? Planning. Good planning. Good radiology-based planning. So again, so let's all take Mandar's message home.
Yes.
Says bleeding is a problem. You're worried about bleeding, and Mandar stresses on prevention rather than taking care of it when it actually.
That you need to take into consideration.
For that, you need planning. You need to go through your scans. You need to understand. But bleeding remains one of your key issues.
Bleeding is something which you are always worried about.
Yes. So again, I would open it out to anybody can take it. Devendra, TORS, you want to take it, or Harsh, Dr. Sawant? Or I'll get back to Surinder. When to anticipate bleeding? Give me an idea. This patient is going to bleed. I have to be ready. I can't take my 2 pegs in the evening. I may be called at night to come and tie it up. How do I anticipate bleeding in patients? Surinder.
Shabir, yes, sir.
Hello.
Please, sir.
Yeah.
Please, sir.
Arun.
Yeah. Kaustubh.
Yeah, Arun. I just wanted to add a point in prevention.
Yeah.
Keep your threshold for putting a flap very low. If the patient is a salvage case, it's a post-chemo radiation case, keep your threshold for putting up a flap.
Radiotherapy is your bugbear, right? Radiotherapy. If it's a radiated patient, keep a flap ready. Get ready for bleeding, right?
Sir, always in a salvage patient.
I'll give you. This is again a meta-analysis which came the laryngoscope, I guess, early this year. Megan Turner, is it Holsinger's group? Yeah. So when to anticipate bleeding? When do you think, yes, I have to be ready?
The first point is the large tumor resection, and basically the base tongue resection lies the tonsillar tumors. So when you're doing a base tongue resections, your lingual artery is the main source of bleeding, and it is not only the antegrade, it is the retrograde bleed also. So you have to take care of that thing also. You ligate the vessel in the neck, but sometimes you cut the lingual artery during your robotic surgery, then you can have retrograde bleed. One.
Lovely. Thank
you. The venous bleed is also very important because sometimes your BP is very high and patient have venous bleeding also.
Right.
So what you do now, we have an exercise system, and in exercise system you have a bipolar system.
Yeah.
So when you use an exercise system for TORS, your bleeding incidence is very low. So what I want to tell you about this analysis, what you are showing right now, is with SI system, which don't have a bipolar system. But if you have bipolar system in your robotic surgery program, the chances of
complications are going to come down. It's much more. Yes. So the device matters is what is, which does not come up in the systematic review, is that even the device, as robots develop, as newer generations come in, probably whatever complications you encounter could further be lowered. Right, Surinder?
Absolutely.
Anybody wants to contribute anything more to this? Surinder, Mandar.
One thing which has been seen, that ligation of a vessel does not reduce the incidence of bleeding, but it reduces the incidence of major bleeding.
Great.
And that has already been shown.
So that is put up as the 4th point. Yes, Mandar. Great.
So,
okay.
Always.
So we have a large review of like the use of prophylactic artery ligation in a cohort of almost, I think, 6,000 TORS cases. And what they said is exactly what Mandar just said, that ligation does not reduce the incidence of bleeding, but it might reduce the extent of bleeding, or it reduces the extent of severe bleeding. But there's a caveat to this. If you look at that review, it's published recently in the Laryngoscope, there were only 4 studies which actually had the surgeons doing ligation. Secondly, the percentage in the entire cohort.
We will come to that. Harsh, give me another. Harsh, give me another 5 minutes. I'll draw you back into the discussion after a couple of slides.
Sure, sir.
Exactly, sure. It's up for discussion. Harsh, okay?
Yes, sir. Yes,
okay.
Yes, sir.
So the significant bleed, you had it now. You had it. What do we do? Mandar, Dr. Dhairishil, anyone who wants to take it. I leave it open to the panel. Dock back in, do a tracheostomy, put in a pack. Endovascular approaches. This is quite interesting. A transcervical artery ligation. I'm sure Surinder would tell me, "Pehle karna chahiye tha."
So
tell me.
Okay, sorry. Go ahead.
A tracheostomy is mandatory.
Right, tracheostomy is mandatory. I want to hear from others as well. What do we do? There is bleeding. You have got a call. You are rushing down. This fellow says, "Are sir, kya ho raha hai? Come."
Arun, I would first say bleeding is like while you are doing a procedure, when you
later.
Okay.
That you control. You have the dog, you have the robot in. Things are under control. Now this happens, say night. When free flaps fail, that's the time when TORS bleeds, and there is edema. The tongue is all swollen up. The anesthetist is worried. What do you do?
See, these are the times where many times it is not usually it's the secondary hemorrhage which is there. Many times happens something like 7-8 days after the procedure, and it becomes if it's immediately after the procedure, then it's easier to identify bleeding and doing. So you secure an airway and you go in and catch it. But many times it's a secondary hemorrhage which is late, and then it becomes difficult to and many times this is a salvage procedure where the neck is already been addressed, or you have not addressed the neck, and then you will have to do something like ligating a vessel in the neck, either by open method or endovascular.
So rarely you dock back in, you go for an open approach at this point of time.
If it's a secondary hemorrhage, then the vessel, the way you're saying, the vessel has sloughed off, and there will be a local infection, sloughing of a vessel, and then catching it in the infected field.
Very difficult.
It's difficult, and it will again not. There is a chance of slipping is there. To be very frank, I'm talking more of a theory than actually
having faced it. Have you faced it, Surinder? Have you faced it?
Yeah, absolutely, sir. So I will tell you my experience.
Yeah.
3 years before, I was using SI system.
Yeah.
And we were not doing any transcervical ligation.
Okay, so there you go.
Great. Now, since 3 years, we are doing transcervical ligation of all vessels, depending on the site of the surgery. And we are using XI system now. The incidence of bleeding is less than 1% now.
Okay.
Even the major or minor, whatever we say.
You do it. Do you do a pre-operative ligation, or do you ligate as and when needed?
At the same time, we do the neck.
Okay.
We do the neck first.
So it's prophylactic. It's
ligate the vessels, then go for TORS.
Which arteries? Is it just the external carotid? Would you choose the lingual or the facial? Or
depending on the site type, the tonsil, we ligate the facial. If it is base tongue, we lingual, or sometimes the ascending pharyngeal also. And if it is supraglottic cancers, then we ligate the superior thyroid branch of superior thyroid.
Yeah. So does TAL is cervical arterial ligation.
It's
So this is the
mandatory in all
question
places
which
nowadays.
Harsh asked. Harsh just asked me that question,
Yes,
you know. Harsh, can you just clarify it for the audience? We just heard a bite from you, but tell us, does it prevent bleeding? What is the evidence on that?
So the evidence suggests that it does not reduce the incidence of bleeding, but it does reduce the severity of a bleed, so that you might have a minor bleed, but it will not
You
be
agree with that, Surinder? You agree with it's your favorite procedure. You do it every time, and Harsh says there is no evidence for it. What do you say?
That's what I'm saying, sir.
No, sir.
All the
No,
data
I'm
is,
just trying to pitch one against the other. That makes it fun,
no, it's
right?
fine.
Come
That's what
on.
I'm telling you.
Yeah.
The data is with the SI system, which
Yeah.
we don't have a bipolar system. Yes,
Yeah.
the data says that the
Yeah.
incidence of major bleeding is decreased significantly.
Yeah.
The minor and moderate bleed remains same.
Yeah.
So this
Okay.
minor bleeding is not arterial bleeding, but it's the venous bleeding basically.
Great. Okay. So that answers your question, Harsh, right? So it's probably you have to distinguish the type
No, sir.
of bleeding
Just like to
and the
add
device. Go ahead.
We have a caveat with interpreting that literature. With interpreting that literature.
Yeah.
So there are only 20, if you see the entire chart, only 25% of surgeons actually used transcervical ligation.
Okay.
So if the number was more, probably we would have some significant benefit in reducing the incidence of bleed as well.
So more studies. You need to plan bigger studies, larger numbers, you know, before we arrive at and sort of, you know, comment categorically on the outcomes of that
Harsh,
study.
if I can come on that.
Yes, Mandar, quickly, we'll move on. I think we are overshooting time. Parin will be very angry with us.
Yeah, so Harsh, that is mainly in US because they are using it for unknown primary where they are resecting. They are not doing a simultaneous
mucosectomies. They do. I heard Uma Maheshwar say that for unknown primaries they take off the entire lymphoid tissue.
Unknown primaries, and therefore they are not ligating the vessels.
Right.
So we are rarely doing it for unknown primaries.
Right. Okay, so again, one more issue with sort of burning issue. One is bleeding, the other is airway, and that is, you know, your tracheostomy comes in. Again, anyone in the panel, you know, want to pitch in prophylactic tracheostomy? When do you think of it? 1, 2, 3. If you can give us a couple of indications where you start, or do you do it for all your TORS cases? I'm sure you don't, Surinder. You don't do a tracheostomy for all.
It depends on the experience. If I'm a starter, I should always secure the airway first because I don't want to die my patient.
So your learning curve matters here, right?
Absolutely.
Right.
You should do a tracheostomy if you want to start it with.
Right.
But if you have an experienced one, you can avoid the tracheostomy at least in tonsillectomy and small base stem tumors.
Yeah.
But if you're doing a supraglottic tumors, you should always do a tracheostomy for exposure. Plus, because the chances of bleeding is much higher in supraglottic tumors, you should always secure the airway.
Okay, allow me to come in here with an issue. It's volume restoration. These are important structures for swallowing. Your oropharyngeal phase is, you know, you transition from a voluntary to an involuntary phase. I think Shamit went extensively through that. I have seen that, you know, so what is the threshold for reconstruction? All, some, few, you know, does it help minimize complications? Again, Mandar.
Arun,
Kannan, anything to contribute? Haven't heard from Kannan in a while. Kannan?
No, putting a flap in the base tongue or in the tonsillar area, I'm not very comfortable because
not comfortable. Okay,
that will lead to more of aspiration, and that might not help.
But you do a tracheostomy and allow it to settle down. That is how we used to do in an open approach.
Yeah.
Okay. Surinder, anything else? Yeah. Go ahead.
Arun,
Mandar. Yes, Mandar.
Every patient where I'm doing a salvage procedure, I'm always putting in a tracheostomy. That is one more indication.
Great. Salvage. So we get the message. Okay.
Dr. Mandar, you can
make a comment. Yeah. Go ahead.
Yes. Shamit, come on, pitch in.
So, you know, I think you covered it great. But one thing I would add about the reconstruction, we know that putting adynamic tissue, potentially adding the bulk which might not be necessary, and compared to a tissue which is still sensate and still healing, has better rates of dysphagia as long as the volume restoration is not required.
So this is something, you know, which will hit the the conventional belief that, you know, base tongue needs to be reconstructed. KK, are you there? You know, both open and robotic surgeon. Shamit has brought in a very valid point. You know, this debate goes on reconstruct, not to reconstruct. Quickly, if you can give me your views, we'll move on. You do both, I know.
So one of the things I would like to add, any native tissue is always going to be a better thing, whether you're doing TORS or you're doing TOLS.
Yeah.
Even if you're doing a laser surgery.
So don't reconstruct until necessary, right? That is the message that you want to give.
Correct.
Surinder, you agree with that?
So if it is a lateralized tumor like tonsil and your vessels are exposed, most of the time you can see your vessels.
Yeah.
You have to put a flap on that.
Okay.
Otherwise,
vessel exposure. Beautiful.
Yeah.
Right. Here we get a point from Surinder that vessel exposure, you're worried about bleed again, right? Not function.
But if the base tongue defect, if your base tongue defect is going up to the hyoid, you have to cover the hyoid bone. Otherwise, this patient requires post-op radiation, and the ORN is much higher in this patient because you're already ligated to the vessels in the neck, and then you're exposing the hyoid bone, and this will be a major problem in post-operative rehabilitation. So you have to cover the hyoid bone, but don't put a volume over the epiglottis so that their patient has a lot of aspiration and you can say dysphagia also.
Okay.
Yeah, I don't know. I would say the larger resections and post-RT, salvage resections probably require...
salvage, large, post.
And tonsils, small tonsils obviously won't require.
And vessel exposure, and small lesions don't. So again, just like our open surgeries, you have to make a call on this. I think I'll stop here. We are not going to go further. It's 8:30 already. It's a Saturday evening. With your permission, Parin, I think we have overshot time by about 10 minutes, and I feel very, very guilty about that. Parin, can you hear me?
We have 10 minutes more to cover this topic.
Oh no, I think 8:30 is time. I think, let's stick to time.
Okay, sir.
Please, with your permission.
Yeah, sure, sir.
Panel, what do you believe? Saturday evening, let's all call it a day.
Have a good evening.
You were wonderful. We had a great panel, and thank you. I hear that I am not able to see anyone of in the audience. I believe, Doctor, there are stalwarts like Dr. Shah. I'm not sure who else are there. Thank you so much for your inputs, and we have always learned from you. Yeah.
I don't know if Dr. Shah is here. He can make some last comments.
Please, I would welcome that. I would appreciate that. It's a learning experience hearing Dr. Shah speak.
Dr. Shah can make some comments.
Please, sir.
I think it was a very informative and intellectual session. I compliment all of you. I learned a lot. And the one point I was trying to raise was the indication for doing a PET scan, the risk of distant metastasis in somebody with a recurrent or new primary confined to the oral cavity with no neck nodes is minuscule, if any. The PET is not going to give you anatomic extent of disease within the tongue. And you are not going to not operate if you wind up seeing one hot spot in the lung. Because this patient's quality of life from the point of view of pain, bleeding, and swallowing would be significantly compromised for the length of life he's going to live. So the point I was trying to drive was PET scan is a luxury, not a necessity.
Okay, point taken. Point taken, Dr. Shah. Sometimes, yeah, I agree. I agree that PET scan, the metabolic information that you may get may not entirely drive your surgical plan. It has been used more as a way of protocol, even though we do customize that for patients who would not. But your point is well taken, and I thank you for your comments, Dr. Shah.
Dr. Shah, this is Dr. KK here. How frequently do you do mandibulotomy nowadays? I feel it's becoming a little...
We do them, although I think the use of transoral robotic surgery has significantly reduced the incidence of mandibulotomy. But there are indications where you may have to do that in selected patients. But clearly, I would say less than 15–20% of what we used to do 20 years ago.
Okay, thank you.
Thank you. So Parin, with your permission, may I sign off? And before I do that, I must thank all of you, your entire team at HCG. You have been great. Kaustubhai, Dr. Toprani, Aditya, Parin, yourself, Dakshesh, Purvi, all others, you have done a great job. And Wonderful, wonderful discussion from a panel. Clear cut messages which gone across. Devendra, thank you so much. Dr. Dhairishil brought in all your experience into this discussion. Harsh, as usual, you are bang on with all the latest updates. Kannan, great contributions, very practical. Mandar, Surinder, veterans of robotic surgery in this country. Thank you so much for contributing so much for this. Appreciate it. And with your permission, Parin, may I sign off?
Thank you, sir. It is an excellent panel. It was an excellent panel, and I'm thankful and grateful to all the panelists as well as the lecturers for taking a kind and very beautiful lecture. Thank you, sir.
Thank you for teaching me. Thank you.
Bye.
Bye.
Thank you all. Bye.
Good night all.
Thank you, sir.
Bye.
Thank you, sir. Kaustubh sir. Bye-bye.
Bye-bye. Thank you.